Day. Good morning, everyone. And dear stakeholders, this is your day. And so it's my pleasure to welcome you at our stakeholder forum of the EU-JAMRAI 2. As all you know, we consider that AMR cannot be fully addressed if all stakeholders are not joining us. And so in this regard, this stakeholder forum is critical for the success of the EU-JAMRAI 2. And your expertise and experience in the field of AMR give an outstanding added value in the joint action. And we absolutely need you to contribute to implement the EU recommendation efficiently. So today we will have 3 roundtables with different panelists, and thank you very much to the panelists for accepting our invitation. We appreciate it really. Thank you so much. So the real roundtable will address first human health, then animal health, and environmental health. So I wish you a very productive working day. And to start with the panel on human health, I'm pleased to call Rita Mori from the SGAP. Thank you.
So thank you very much. First of all, to invite me here and have really a great inspiration. First of all, I'm Rita Murri. I'm a so-called end user because I'm an infectious disease specialist working in a very large hospital in Rome, Italy, Gemelli Hospital. So I'm the head of the consultancy unit, so all my work is doing consultancies for infectious disease problem and promoting antimicrobial stewardship and optimal antimicrobial therapy for any infectious problem. So I'm here as an end user, but also I'm the privilege to be part of the executive committee of SGAP, that is the group of ESCMID, probably you know, that is involved in antimicrobial stewardship. So I represent here more than 500 members, perhaps. And I have also the privilege to be part of the WHO antimicrobial stewardship coaching program. I don't know if you know it. It was really a very nice experience. So I'm an end user also from an education point of view. And we host in Rome also an advanced module of the antimicrobial stewardship certificate from ESCMID. So another opportunity to meet people and to discuss together how difficult it is to implement tools, guidelines, and also theoretical approach in the real life. So I'm very happy to be here to promote a discussion about, this is really the title of this session, so advancing in human health from paper to practice, ensuring the JAMRAI's impact on the front line of antimicrobial resistance. So the big context is, again, antimicrobial resistance. That is our tremendous problem for which we are here. But now we would like to discuss about how JAMRAI deliverables, products, and also videos and activities can be implemented in the real practice. So JAMRAI staff are really interested in this discussion. And it's very interesting for me also how strong is the approach in One Health vision, because here continuously we talk about animal health, environment health, and human health as a big one, the One Health. So this is very interesting also from my part. So it's my pleasure now to introduce the panelists of this session. I can call them one by one and asking them to introduce themselves and let us understand how their activity in the organization or in the agency they work are linked, are related to the issue that we are now discussing. So how is the link with the JAMRAI goal, especially? So it's my pleasure to call, first of all, Diamantis Plakouras from ACDC. I think that we have no need to, yes. Yeah. So you are from ACDC, so I let the floor just to introduce you and let us understand the link with the JAMRAI activities.
Thank you so much, Rita. So yeah, my name is Diamantis Plakouras. I work at the European Center for Disease Prevention and Control. I'm currently acting head of section on the microbial resistance and healthcare-associated infections, and of course, virtually every area of JAMRAI work has something for us, because at the CDC we're working on surveillance of antimicrobial resistance, antimicrobial consumption, and healthcare-associated infections, but we're also working with scientific advice and country support for on AMR. We're also working on, we have some training activities. We are also doing risk assessments and looking at event-based surveillance, for example, through looking at outbreaks in Europe of either emerging antimicrobial resistance or specific healthcare infections. So everything that JAMRAI is doing is relevant for us. And I forgot to mention communication, which is also very relevant in our area, and for example, with the European Antimicrobial Awareness Day, which is basically a milestone for ACDC work every year. So we had the privilege from the beginning to work with JAMRAI partners, even from the planning stage. And we have been collaborating quite closely, more with some work packages, a bit less with other, but eventually we have been involved almost in every area, especially concerning human health. For example, in the area of infection prevention and control, where we were lucky enough to have JAMRAI support because we have been working on development of infection prevention and control guidance. So JAMRAI has supported this work, for example, through the systematic review and recommendations on diagnostic stewardship, which is part of this guidance, and also a very important support has been through the development through the update and review of the ECDC Director of Online Resources for Antimicrobial Resistance, Antimicrobial Stewardship, and Infection Prevention and Control. This will be a complementary work for the IPC guidance, because the guidance that we will be developing and we will provide to the European Commission to finally publish as in probably sometime in 2026, probably in June. This refers mostly to components of infection prevention and control programs, and how to establish and implement some such programs. And then the Directory of Guidance will provide all the more granular guidance specific on specific infections or microorganisms. We have also worked together with microbial stewardship, and we have supported the work of the respective work packages, both for primary care hospitals and long-term care facilities. And this is also very, very important for us, because appropriate antimicrobial use is central, is key for the control of antimicrobial resistance. And I think there are also further, and also very importantly, and we'll probably talk more about it later, the work on behavioral change for antimicrobial resistance on infection prevention and control. This also has been very central in the guidance that is being developed, because, I mean, implementation is basically the bottleneck right now. I mean, we have very good data in Europe. I think we are privileged to have very good data. There is room for improvement, of course, especially at the local level, but we have good data. We have the evidence. We know what works. We have also guidance. There is guidance. The problem is implementation, and I'm happy to talk about it more later. And finally, I would like to say that the work on behavioral change will also guide and inform our further work on practical operational application of behavioral change insights from behavioral change science and implementation science in the implementation of guidance.
So thank you very much, Diamantis. There are a lot of things of which we
talk all day.
Yeah, absolutely. So it's my pleasure to call here Boumediene Soufi from Medicine for Europe. You are here representing Medicine for Europe, so please introduce yourself and your organization, just to let know what is your activities and how their activities are linked with the JAMRAI project goal.
Yeah, absolutely. Pleasure to be here. Good morning, everyone. So I'm going to try to make sense. I have to admit this light's going to be a little bit of a challenge, so maybe someone should actually push the black button and see if this reduces the light strength. Yeah, pleasure to be here. So my name is Boumediene Soufi, but feel free to call me Bo for short. I am the global head of the antimicrobial resistance program at Sandoz, which is one of the members of Medicines for Europe, and I'm very proud and privileged to be able to represent Medicines for Europe today. So Medicines for Europe really is the voice of the generics and the biosimilars industry, and Medicines for Europe really strives to ensure the access to patients to responsible use of these medicines, but also to ensure that Europe has access to quality-assured, affordable medicines, while in parallel ensuring that the healthcare ecosystem is sustainable for generations to come across the continent. What I would really like to deliver to all of you today is, hopefully, if it's one takeaway message, it's that access and stewardship are the same side of the same coin. We cannot steward things that we don't have, and we need to ensure that the market framework is resilient and rewards supply resilience, so that ultimately clinicians have access to the first agent that's most beneficial to the patient, right? And avoiding this escalation to broad spectrum use. Because ultimately, even before we talk about resistance, the first question is, we need the market framework in place that makes sure that the agent that's needed for the patient treatment to have the best outcome is there, full stop. Then, of course, the second element is, by avoiding this escalation to broad spectrum use, we can avoid any sort of exacerbation or complications on the resistance side of things. So number one, we need to make sure, whether it's a reserve antibiotic or a narrow spectrum antibiotic or low volume, does not matter. It's the right treatment for the right patient at the right time, independent of what country the patient is in. So that's kind of the angle that I would like to talk about with all of you today, and also with the panelists. So looking forward to the discussion. Thank you.
So thank you very much, Bo. We will come later on this matter, this issue. It's my pleasure to invite Johan van Heldere from European University Hospital Alliance. Again, introduce yourself and, as you prefer.
Good morning, and thank you for having me. My name is Johan van Heldere. I'm here on behalf of the European University Hospital Alliance. We are a fairly young organization, and we include 11 of the largest university hospitals in Europe. For example, here in Vienna, the AKH University Hospital is our member. Yes, so again, my name is Johan van Elderen. I'm here on behalf of EUJA, European University Hospital Alliance. We're a fairly young organization, including 11 of the largest teaching and research university hospitals in Europe. Our aim is to support the sustainable European healthcare system. A European healthcare system that is distinguished by the fact that it delivers top clinical care, is based on research and innovation, and is equitable, meaning that it has equal access for everyone, whether you be rich or poor. And don't be surprised, but this system is under pressure. There's a lot of pressures on this system. There's the workforce problem, there's demographics, there's the increasing price of drugs, especially in the cancer field, and there's the geopolitical changes. And so what we want to do is to take action, to do projects, but also to be advocates at European level for the sustainability of healthcare systems, European healthcare systems. And this brings me to AMR. AMR, antimicrobial resistance, was not one of our priorities. And my main point today is going to be that for hospital managers, antimicrobial resistance is not a priority, not a priority. And if there's one advice I could give you, that is, make it a priority for hospital managers. I mean, I've seen a lot of very good initiatives talking about IPC teams, talking about all other people in the hospital. They're convinced. You don't need to preach to the converted. What you need to do is preach to the hospital management. And again, AMR is not a priority. There's many other priorities: the workforce problem, cybersecurity, the green transition, resilience, preparing for war, preparing for the climate change, and everything else. AMR is not on their priority list. So what you need to do is make it a priority. And this will include looking at ways to convince hospital managers that an advice of an IPC team is not a nice to have, but is a must follow. That IPC teams need to be supported, and that their advice is not there just to have, but is there to be followed. I think that will be my main message today. And just for full disclosure, I used to be a microbiologist, and I'm married to the head of the IPC team in my former university hospital, who's at Leuven.
So, thank you very much, Johan. You anticipated a lot of things that we can discuss in a few minutes. So it's my pleasure to call for Camelia Bogert from IPC Nurse Corner. So thank you very much to be here. Please introduce yourself and your activities.
Hi, good morning, everybody. Yes, I'm an IPC nurse. I work in an acute general hospital in Belgium. And as an IPC nurse, I see in the daily practice that infection prevention and antibiotic stewardship activities live or die at the bedside. Because we have guidelines, we have a lot of guidelines, we have good guidelines, we have books of guidelines, but actually there at the bedside it happens or it happens not. So, yeah, when I realized that as IPC nurse, I started to look for, to connect with people, to see how we could improve that implementation at bedside. So I did my UKIC training, and during my UKIC training, at each module that I've have been to, I asked, could I meet your IPC nurses, your local nurses, to talk to them, to ask them how do they implement guidelines in your setting. And from that, going through the modules and then finishing my UKIC training, I got the idea to create a network of IPC nurses that communicate on a low-level manner. So we actually created an IPC nurses network this year. This initiative is under the umbrella of ESCMID and EU-JAMRAI. it seemed to us the best way to create it under the umbrella from EU-JAMRAI as a part of the activity of EU-JAMRAI, and not to create some separate initiative, some separate website somewhere where nobody could find it. So let's one message. Let's bundle our strength. So you can find that page there, and. So what is the purpose of this initiative is to really translate or to see how different nurses from different settings are implementing things. The main issue that we encounter in everyday practice is that new guidelines, new reports are arriving on a level that is already overloaded. My IPC physician and my AMS physicians have already a full agenda. They receive guidelines, 40, 50 pages that they have to make time to read them. Sometimes those guidelines are given to the nurses also to read, but not always. In not all the hospitals is a good communication between physicians and nurses. That's something that I think it should improve in the future. And there's one more aspect. I would like, in an ideal world, to make more friends between IPC and EMS. Let's try to build a bridge between IPC and EMS because, I mean, the two are, it's important to create that bridge. It's important to create it not only on the physician's level, but also on the nurse's level. Nurses don't dream about prescribing medication and about other difficult stuff. They just dream about understanding why some decisions have been made for patients. Because if they understand that, then they can support more, even more from IPC side, the success of those decisions. So, happy to be here, happy to join the discussion.
Thank you, Camelia. Really very inspiring. Again, the implementation is the key word of this roundtable. And it's my pleasure to call for Hette Nygaard Jensen from Imagine and give you the floor just to introduce yourself and the activity of your association.
Thank you. Thank you for the organizers for inviting me. My name is Jette and I'm from Denmark. I'm a senior researcher, and the reason why I've been invited is because I'm a representative from the project called Imagine. Imagine stands for Improving Antibiotic Use and Infection Prevention in Long-Term Care Facilities. So I talk from the context of long-term care facilities. And Imagine, I just want to say very little about the Imagine project. It ended 30 days ago, and it was a 3-year EU-funded project. And it was the aim of Imagine was to improve infection prevention and antibiotic stewardship. So there was 2 in 1 in this project, IPC and antibiotic stewardship. And the results of the 3-year project here, Imagine, were good. We managed to improve 17 out of 29 IPC elements significantly. We also managed to reduce the number of UTI-treated and antibiotic-treated UTIs with 27%, and we reduced the unnecessary antibiotic with 13%. Very good results, and we are very proud in the consortium. But we were also very relieved because many of us in the Imagine consortium has also done another EU project, another 3-year EU project called Happy Patient. It ended about 2 years ago, and the results from Happy Patient in relation to antibiotic use in long-term care facilities, they were not good. Actually, in one of the 5 countries that participated in the Happy Patient project, the antibiotic use increased after our project. So bear in mind that we were very proud that the Imagine project had so good results. And if you are going to ask me, which I hope you are, why did you get so good results in Imagine? How did you manage? My answer will be, that was because we included the end users from the very start of the Imagine project. The end users were participants from 8 countries. We were 8 countries in Europe, and we were more than 400 professionals, long-term care professionals. They were included from the beginning, so they were a part of the participation process. They were deciding what we should investigate and what decisions we should make, and also what analysis and what tools, what we should develop and how we should implement. And so I think that was the word from me. Yes, thank you.
Thank you very much. Thank you very much, Hette, for this inspiring speech. And let me introduce, if is linked, Dr. Pilar Asler is online, perhaps, we hope. So Pilar is from Wonka. Are you there, Pilar? Probably not yet. Okay, maybe we can wait for Pilar, for the Pilar link. I think that we have a lot of...
Could you hear me?
You are here, so...
Yes! I've been listening
nice.
to you.
Welcome, Pilar,
you
to
so
our
much.
meeting. We are very happy that you are here with us. You are from Wonka, so please introduce yourself and the activity for which Wonka is related to the JAMRAI project goals. Thank you very much.
Thank you. I would like to...
There is some problem with the audio.
Hello again.
Yes.
Now it's work.
Yes.
Good morning to all participants in Vienna. I would like to thank you, the JAMRAI committee, for the invitation to the Global Organization of Family Doctors worldwide. I apologize for not being there in person. I'm grateful to the technical team is making this digital connection possible. It's a privilege to share this panel with such a distinguished group. Thank you, Rita, for moderating, the Yamantis, Boumediene, Johan, Kemeli, and Jet. Nice to meet you. It's truly a kaleidoscopic human perspective for antimicrobial stewardship, spanning from the epidemiological surveillance of the ECDC to behavioral insights of the imaging team, as Jetta said, and my presence here with the family medicine perspective. I'm Pilar Astier, a specialist in family and community medicine, and also a specialist in preventive medicine and public health, and I work as a frontline family doctor in Zaragoza, Spain, and also a professor at the University of Zaragoza. I've been working with clinical risk management and implementing healthcare quality models, contributing to patient safety through elaboration of national and international strategies, and also recommendation for antimicrobial stewardships. My research career is focused mainly on translating complex safety research into practical data-driven tools that empower primary care teams to provide quality and safer healthcare. That's the meaning of the EU-JAMRAI 2 now, from paper to practice. So family doctors, we are working in primary care team with nurses and pharmacists. We manage the human perspective of the One Health access across life course, from the first pediatric fever to the complex infection of the elderly. This longitudinal connection is our most powerful tool. Throughout my career, I have come to view that antimicrobial stewardship is a fundamental patient safety intervention is key. So Wonka mission today is to advocate for a transition from paper to practice by ensuring the safest prescription possible is supported by a resilient primary care team-based system approach. So Wonka stands for enhancing the role of family doctors in primary care through training about antimicrobial stewardship, doing research on the implementation process as the Imagine project is launching now the results, and also to quality performance accreditation process of our primary care facilities around the world that will enhance this specific optimization of antimicrobial prescription options. So I appreciate deeply the invitation to have family doctors on this panel as we implement this optimal prescription of antibiotic every day. Thank you.
So thank you, Pilar, for your intervention. Thank you very much. So it's time to go deeply, and I would like to pose the first question to our panelists. I give the floor one by one, and we ask you to help us to focus on challenges before. So we are now witnessing a lot of changes in our healthcare system. So there are many challenges that I think we can see in infection prevention and control and in antimicrobial stewardship. So first of all, which are, in your opinion, the main challenges that we are witnessing now? And try to let us help in what are the challenges that we need to resolve or to afford, especially as JAMRAI project want to do. So first of all, Diamantis, challenges and also the way to meet those challenges. So some ideas.
Thank you very much, Rita. I think we already have somehow pointed out a number of challenges, and it seems we all agree that one of the main challenges is implementation, but of course there are some other systemic challenges that perhaps they need more an overall overarching approach. So we heard about staff shortages, which is a key issue across healthcare systems in Europe. And these staff shortages lead also to work overload. And this is not a perfect condition for appropriate antimicrobial use or appropriate infection prevention and control. And there are also, there are also often lack of funding, both in the healthcare system, but also in public health. And we have seen that, especially after the pandemic, that funds have shrinked a lot in public health. Excuse me. And but eventually, I think there are also areas that there are things we can do, and where JAMRAI has been working on, and this brings us back to the implementation challenge. I think it's very telling that we know, for example, the effectiveness of hand hygiene. Right? I mean, there is no doubt how effective hand hygiene is, and yet what we see is that appropriate hand hygiene only happens in around 40, in the best cases, probably 40 to 50% of opportunities for hand hygiene. And in some places, this is even lower. In some places are privileged to have higher compliance, but eventually this is one of the biggest problems. And I think it highlights that the main challenge is implementation. So we know what has to be done, but somehow we have failed to make it happen at the bedside. And that's why I think it very important, one of the strong points. And for implementation also, we know that a number of factors play a significant, considerable role, but behavior is key. And that's why the work and harnessing the insights from behavioral sciences and harnessing the insights from implementation science is very important in this area. So we need to make sure that we work together and that we bring in the field scientists with knowledge on behavioral change and implementation science to support work and interventions that really work and make a difference. And this is important both for infection prevention and control, but also antimicrobial stewardship, because these are the two key elements that are necessary to fight antimicrobial resistance.
So thank you very much. This is, I think, an aspiration summary, I think, also for JAMRAI project. So you mentioned some very easy to understand challenges, but also a pathway for working and for meet needs. So implementation science and all the part of the project that are working on behavioral changes. And yesterday we saw a lot of deliverables and products that are going towards with this purpose. So very interesting. So I give the floor for the same summary for both for the medicine and Europe. For Europe perspective.
Thank you very much, Rita. So obviously there's a lot of challenges, we know them. I would like to call out 4, if I may. So we'll try to keep it to 4. The first one is that resistance is rising where it's hurting the most. We heard from Christine on day 1 talk about the rise in bloodstream infections across the EU, especially in those very serious multi-drug resistant carbapenem organisms, and of course that undermines the power of AMS and IPC efforts on the clinical side. The next 2 really come down to our market framework, right? So you mentioned shortages. We remember the recent shortages and just the dramatic, terrible effect it had, especially in the pediatric population. They still happen. They're still recurring. That's directly threatening the efforts of stewardship, again, because you don't have it. And of course, when you look at procurement policies, they're very restrictive. It's undermining the importance of supply resilience. So why is that happening? On one side, when we think about costs to manufacturers, what's essentially happening is cost of goods is increasing, inflation is rising, energy costs are rising, as well as regulatory costs. And so you have this cost pressure on one side. Think of it like a formula. Now add the fact, on the other side of the equation, you have pricing pressure. Pricing pressure on the manufacturers. Why? Because of restrictive procurement policies, also pricing policies. And what that essentially does is it puts pressure on the manufacturers, and you see a market consolidation effect occur. Less marketing authorization holders, manufacturers are exiting, and the critical medicines we need, the first-line treatment therapies, either become limited to one marketing authorization holder or, unfortunately, in some cases, completely exit the market. And so this, of course, increases the risk of shortages. Why does that matter? Because ultimately, what we're doing is, if we're losing the power of these first-line access antibiotics, essentially what we're doing is we're reducing the effectiveness of the treatment to the patients and increasing resistance, again, as I mentioned in my introduction, because of this pressure on, more broader spectrum use, right? And ultimately, it's the patient that pays the price, right? And the last challenge, I would say, is a delinking, if I may call it like that, between AMS and IPC targets and controls with the AWARE goals, right? So the AWARE classification of antibiotics. The European Commission has stated, at least 65% or more of prescribing should be the access group of antibiotics, a narrow spectrum first, and this is, caused by, let's say, guidelines not being followed across the board, or a lack of sufficient data that basically, increases these gaps. I would say, from a challenges point of view, those would be the main ones I can highlight. And of course, it's not all bad, so there's progress, right? And I guess we'll come to the progress in a second, but those would be the main ones that I see.
Thank you very much, both. Sorry, do you have some practical examples on how the drug shortages can impact on antimicrobial stewardship in Europe, for example? Just one or two examples.
Yeah, absolutely. So we did this analysis. If you look at all shortages that occurred between 2023 and 2024, actually 2 out of 3 shortages had a low marketing authorization count. 2 out of 3. And these were all critical antibiotics, Pen-Vs, amoxicillin, and a really, really bad impact on the pediatric formulations especially as well. So the facts are shown. It's there. Shortages cause a direct correlation between market exit and an impact on stewardship. So
yes, thank you very much. Thank you. So the floor to, I think, to Joan, just to respect the order. Challenges again, how to meet the needs. And especially focusing on what you are saying, so antimicrobial stewardship and IPC are not a priority now in our hospital management and also governmental vision. So this could be considered a main challenges or not?
Absolutely. And so the question is how to address this. Implementation, of course, is the buzzword that has already come up several times. I heard this thing about behavioral change and everything. I think to change things, you need the stick and the carrot. Let me tell you a little bit about the stick. First of all, yesterday I heard from Michael Borg that the system is dysfunctional because it doesn't address this problem. The system is not dysfunctional. The system is functional. Because AMR is not a priority, it's not within the system. Yeah. That's logic. So how do you get AMR in the system? Well, there's also a big responsibility, and I think that is something JAMRAI could work on, in terms of the politicians and the public perception of AMR. It needs to increase. And there's one argument that I haven't heard the past 2 days, and that is that there's a clear connection, and there's been meta-analysis to show this, there's a clear connection between people losing faith in the healthcare system and people voting for extremist, non-democratic parties. So can you imagine a future where people would fear to go into a hospital because of being contaminated with multi-drug resistant organisms? So this argument that AMR is also something that is not the only reason that people would lose faith in democracy, but could be one of the reasons that people lose faith in democracy, is a powerful argument that is not sufficiently used towards politicians, towards the general public. The second point I would like to make, that is hospital managers are there to balance the books. So at this moment, whether you like it or not, antimicrobial resistance is not something that is important. In many countries, it's even an advantage of having people for a longer time in the hospital. So all these studies that show that AMR is having an enormous impact on the costs of healthcare, yes, but not at the hospital level, or at least not in all countries. So how can we convince hospital managers to make AMR a priority? Well, one of the things we will be trying to do within our alliance, we regularly get all our CEOs together. One of the things that I found appeals very much to CEOs is to benchmark what is happening in their hospitals. There's no CEO that likes it when, the benchmarking shows that his hospital is lagging behind these other big university hospitals in terms of something. Immediately, he will go back to his hospital and say, this needs to change. So what we will be doing, for example, one of the things we would like to do is to see how are IPC measures, antimicrobial stewardship, how are they implemented? We're not going to look at the levels of AMR. There's too many variables that play into it. But how are IPC measures implemented in your hospital and benchmarked between our hospitals? And we think this could be a powerful initiative for CEOs to accord more importance to IPC. IPC is not only about IPC nurses, it is also about the design of hospitals. Our hospitals at this moment are not designed to combat AMR. We're evolving slowly towards single patient rooms, but still we have waiting rooms where patients mingle, where there's probably an enormous spread of AMR-resistant pathogens. Do not forget that, especially in our university hospitals, we care for the most fragile patients, often with many multi-drug resistant organisms. And another issue is that we need to make AMR more of an issue when we train our specialists. There's lots, and this morning we already discussed this. I've taught microbiology and antimicrobial resistance at undergraduates. Do not think that when they arrive in the last year of their medical training, they still know what I taught them in their third or second or whatever year. It's at the level of specialist training that habits are made. It's their colleagues that will tell them use this or that or something else. And there we have more impact if we can there oblige them to use the right antibiotics at the right time. That will have a major impact. And maybe one last advice. I've seen a lot of data in the past 2 days. Data without action is distraction. You really have to do something with these data. I've seen so many European projects that said, we're going to create a website, we're going to create a dashboard, we're going to create guidelines. Almost every European project tries to do this. It is, as already been mentioned by other speakers, there's so many guidelines, there's so much information. Please try to put it together with existing ones and come to a harmonized website or dashboard or whatever with the scientific organizations, but do not add to the overflow of information that is already there. And this leads me to my last point. You put a lot of emphasis on IPC and AMS. It's true, but again, you're preaching to the converted. And one of the things we learned after COVID is that if you put more emphasis on the responsibility of people in the hospital, people that already have given everything they had during COVID, you chase them into burnout. So be very careful, but what you add to IPC teams, be mindful of the fact that these are people that are already putting a lot of effort into what they are doing. Try to address the other people that need to give the IPC teams the means and the people and the funding that is needed to do. And maybe as a last example, one of the hospital directors of a big university hospital in my country had to resign because he didn't follow the advice of the IPC team, but only after there had been problems in the intensive care unit. So IPC advice should be a must follow, not a nice to follow, when the management thinks it is useful.
Thank you very much. Again, a lot of things to reflect even later. Thank you very much for the pragmatic vision. And okay, so I leave the floor to Camelia for challenges from your perspective and also how we can meet needs.
Okay, so you heard a lot about the global and European problems and big hospital problems. I will go back to my micro implementation level in my suggestions. So I had a discussion with a physician, with an infection prevention physician during ESCMID 2026. And I asked him about how his team is functioning and challenges that he has. And he said, yeah, we should try to do something about our nurses. I mean, how are you like that? And which courses did you do to dare to speak to us? And because my nurse it's like happened yesterday, she came back from a meeting about a new building ward, and she was almost crying. What? because there are a lot of resistance from the builders, from the management, from the hospital. Why do we have to do that? Why do we have to have ventilation? Why do we have to have a wall or not to have a wall somewhere? And the IPC nurses are sometimes alone in this kind of meeting. Huh? And I told him, and why don't you go with her from time to time to these kind of meetings? Why do you leave her to be exposed to that? So it's not a criticism to physicians, not at all. But it's actually something that I implemented in my own hospital, because Diamantis talked about hand hygiene compliance. And as an IPC nurse, I have to go to do the rounds for hand hygiene observations and for basic hand hygiene, the basics from the hand hygiene. And from time to time, I have some physicians or persons with resistance, meeting with resistance. I have 90% compliant personnel, and I have 10% which are hard resistant. So I said this year to my physician, you will come with me to the next round. I don't care about your full agenda. You will come with me and we will go together on all the wards, and you will talk to your colleague physicians, because they don't listen to me. They need to hear it from you as a physician. And it worked. It works so much better. So I think I have a suggestion about challenges IPCMR: accountability and supporting each other. When you write those guidelines, try to make also the short versions of it. You know, when you look in one pager, you have 30 pages of why we are doing something and all the evidence and all the explanations. Try to add one page about we do that, and that. And in that one page, try to add also the accountability. The physician does that, the nurse does that, and the patient does that, because that's a huge hole about involving patients in IPC and EMS. And we need those tools. That is what we need in the practice. We need a translation of that guidelines to the practical part. And we need accountability, because there should be done. And the question is in the practice, who is the person or the profession that should do that? And how should we do that? So I think there needs to be some more cooperation. Get the physicians out from their lab to go to the rounds, and get us some more involvement, work some more together, and when you write something, put it there who has to do it. So
thank you very much again. Other suggestions for thank you. Other very useful suggestions for also for JAMRAI project. Thank you very much also for us, for end user. And I give the floor to Gerte.
Yes, thank you very much. Like you, I also have one word. You had accountability. I also have one word for this. But I would first say that I've been here the 2 first days, and I've been very impressed about all the good intention and plans about implementation and how to move on further. So I thought, well, what can I say that has not already been said? And one word comes to my mind when it comes to implementation in long-term care facilities, but also in other facilities, and that is sense-making. You were also talking a little bit about it, but sense-making is so important for the end users. They need to understand why they have to follow the IPC guidelines, or why they should not give antibiotic or initiate antibiotic treatments. Let me give an example from the Imagine project. In the Imagine project, we made this IPC audit, and the results from the 8 countries showed that in most of the countries, the nursing home staff, about 60% of them were wearing rings, jewel, they had long nail polish, they had long nails, and that is an absolutely no-go. I'm not an infection control nurse, but my colleagues say that is a no-go. And how can we intervene for that? Of course, we can tell them why they cannot have nail polish or wear rings or jewels when they take care of the resident. We need to make that clear for them. That was one example. Another example is also that in Imagine we looked at the antibiotic use, and nursing home residents, they are treated for UTIs very much. And what we measured was that about 55% of the treatments for UTI, they were unnecessary. And why is there so much unnecessary treated UTIs at nursing homes? We could look at the indicators or the signs and symptoms of the residents. One of the most prominent symptoms for UTIs were confusion. Then you had fever, smelly urine, but that's not very specific symptoms for a UTI, but the nursing home staff, they associate it with a UTI. So you also need to tell them and to guide them and say that this is not real symptoms, but it has somehow become a culture. So I think that it is important to make it very clear why it makes sense. All these good projects and intention, we need to be more clear and more specific, because that's also how we can engage, and then the implementation will be a success.
Thank you very much, Grete. Another key word is sense-making, and thank you for the perspective really from end users, even with the last example. Thank you very much. So I give the floor to Pilar, if she's here, just to let us know which is her perspective on challenges in this moment, and what we should do to meet the needs that we perceive.
Thank you very much. I completely agree with Jet from the Imagine project. The sense of making is really relevant. The central challenge we face in primary care teams around the world, as well as in Europe, is a daily implementation gap between guidelines and day-to-day practice. Currently, there are different issues that we need to address to reduce this gap. One hand, we need to invest in post-COVID educational research. Family doctors have a central role on antibiotic stewardship. We need to support family doctors, and particularly family medicine residents and primary care nursing staff in returning to diagnostic parsimony, moving away from the broadest spectrum caution of the pandemic to a better performance based on rapid tests, epidemiological context, and to adapt the treatment to patient health risk based on the accessibility to electronic health records, previous antibiotic resistance profiles. And moreover, we need to improve primary health care health information systems with easy access to guidelines and decision support tools to improve antibiotic prescription and to improve IPC recommendations, alerts, pop-up measures, so we can have easy access on the electronic medical record and electronic prescription record. We also need feedback. The health professionals, we need feedback through patient safety and quality indicators to set up goals on specific infection disease treatments along time. We have some organizational barriers too. We cannot change behavior without addressing time constraints. As Jet agreed, from psychological perspective, the pressure of a few-minute consultation often drives just-in-case prescribing, and we need to assess as well IPC measure implementation with audits, observational implementation of IPC measures within primary care teams. We need rapid point-of-care diagnostic tests to support our team's decision-making, considering prescribing or symptomatic treatment and watchful observation instead. And also the fact of living with patients' expectations to have a quick recovery from infectious problems, because they have the belief that antibiotic use may lead to a quick recovery. Finally, we have to engage again the community to sustain infection prevention and control together. We need to support guidance with primary care nurses and our community activities with community stakeholders, means social prescription strategies, therefore to raise awareness in civil society that can act on infection prevention and control activities in all the health system continuum. It also will reduce environmental resistance and of course the ecological impact of wrong use of antibiotics. Thank you very much.
Thank you, Pilar. Thank you very much. So I think that we have the opportunity to have a second round of opinions and suggestion and intervention. I write some keywords that I think raised from the first round. So first of all, implementation, this is the keyword, and probably we go deeply in this, the meaning of implementation. Accountability, sense-making, easy accessibility, benchmarking, rapid diagnostic. So probably there are many other keywords, but these are something that probably can drive us to the next phase of our roundtable. So I would like now that you can underline or stress how we can go from the papers, guidelines, amount of books of papers to the practice, to the end users. So how we can use some of the many of the products that we have seen now in these days. I take some notes. We have seen videos for communication. We have seen dashboard. We have seen platform, not only guidelines. We have seen a lot of work on implementation methods that I want from you to understand how can be useful. So how can we help JAMRAI to continue this big effort to go from the papers to practice? Looking at implementation, I think that we can identify, I think, three pathways. One is the implementation from, for example, JAMRAI products to end user. Okay. One is the implementation from end user to the practice, because this is the main issue of implementation science, how the implementation science can educate end user to change behavior, but also something raised about how to implement, how to let an implementation with hospital management or governance, because also in this case there is a very big need. So just some of your opinion on how to support the passage from papers, from theory, from guidelines, from amount of books to the real practice for us, for end users.
And again, no, thank you so much. I think this is a key question, and I think there are three components that I would like to point out. First of all, that whatever is done has to cover a need of the end user. So this is I think, a prerequisite that it will be useful. And I think on this, JAMRAI has done a lot, because first of all, I mean, JAMRAI has among your ranks many end users, and I think this is very important. And so it has to cover the needs of the nurse on the bedside, of the IPC professional, of the prescriber. And I think this is one of the key factors that will, in the end, guarantee the usefulness and the applicability. The second is, I think, building up on what already exists. And I think we've seen very nice examples these few days. Yesterday we heard about that JAMRAI actually supported a course on antimicrobial stewardship that was developed by previous EU-funded project, the Drive AMS, for example. I think this has been a very good example of how to multiply the value of already existing work. And there's a lot of good work that has been done in Europe. And I think it is excellent that JAMRAI has been really building on this. And I think another example is obviously Imagine here, and I think there is a lot to be gained from this. And these are actual projects, interventions on the bedside together with the end user. And this is a really amazing strength of this work. And the third is to take advantage of synergies. So we see how many actors we are sitting already here, and there are so many more. Many of you are sitting in the chairs of this room, and we're all working with a common aim, with a common target. Coming together and working together and using and multiplying the work of each other is key, because we need to reach an audience that is really very broad across Europe. It's the healthcare providers, it's the hospital administrators who heard about the importance. It is also the public. So the synergies, and here, for example, I'm thinking about the work on European Antibiotic Awareness Day and all the excellent work on communicating AMR that we heard about yesterday. And I have been thinking since last evening how we could actually make this come together, and so that each one supports each other, because then we will see really much stronger effect. Thank you.
Thank you very much.
Thank you. So look, I think the EU-JAMRAI 2 initiatives have been so useful. We need to applaud everyone in the room. It's the right thing to do. Why? Because it's focusing on implementation, but with the One Health approach in mind. So when I think about, and it was already said, how do we translate these practices to policies and make sure it gets to the bedside? Because ultimately, that's the question. Number one, link the IPC and the AMS targets with the European Commission's recommendation on this AWARE following, right? So 65% or more should be prescribed in the first-line access group of antibiotics, and also this 2030 target to reduce the consumption by 20%, number one. Number two, make sure clinicians continue to have access to what they need when they need it. So now I'll be the optimist. We're seeing progress in some areas. We have the Critical Medicines Act that is trying to fix this issue with tenders by employing this most economically advantageous tender criteria, which is really important because it looks at things beyond just price. It looks at environmental factors, quality assurance, reliability. Very good, but we can do more. Keep the HERA and EMA shortage monitoring mechanisms in place. Super critical, keep it, right? Because we've seen in the past what happens when we have a demand surge coming from seasonal variations, right? We cannot be in a position to have our clinicians be forced to use something that's not optimal. So keep that mechanism in place. Make sure we have supply resilience. Keep the production of these critical antibiotics in Europe. Invest in it, from the API to the finished product. Make sure that we are capable to continue to produce here, right? It's really of utmost importance. And this allows the manufacturers to stay, to produce what is needed, but also to reinvest, right? So it's a continuous circle there. And I would say the last part is, and the key word was already mentioned, I'm gonna resonate it because it's completely true. If you wanna make EU-JAMRAI results alive, it's accountability. Accountability to the politicians. Make sure the IPC and the AMS targets are implemented into policy. Accountability to the hospitals, make sure they are following this, that the efforts are helping the national action plans, right? Filling in the gaps between guidelines to practice that ultimately lands in the bedside. And accountability also to politicians to make sure that AMS and IPC targets can only be effective if we ensure that the market framework is focusing on access. So link access and stewardship together, they're one and the same. That's how you make progress. And also we see, I'll continue on the optimistic side if I may for a second, we see great efforts here. Look, we heard about the guaranteed revenue model that the Nordics are doing. That's what we need more of, right? Harmonize the guidelines, figure out what is the true need that the antibiotic is used for what indications, build up that capability to sustain these essential medicines. Fantastic. We need more of that across Europe. And as we heard, I hope more countries jump on board. That's what we need, right? So I think the key word is accountability, make sure we have access to what we need when we need it. But also, ECDC, for example, amazing data that comes out. Can we be proactive instead of reactive? We all know how difficult it is to predict resistance, but can we use the data that ECDC gathers to say, okay, in a scenario, if resistance goes in this trend or that trend, what is the product portfolio that we would need to address these new resistance challenges? How would AMS and IPC actually need to be changed in light of these, resistance changes? Now, I understand it's very difficult to predict, but at the same time, we have to be as proactive as possible because we see what happens in the past when we're reactive. So I'll leave it there. Thank you.
Thank you. Thank you very much.
Thank you. It's becoming increasingly difficult to say something that hasn't been said before. So what I will be saying will be, to a large degree, a repeat of what's already been said. The first thing, again, is when you're making your guidelines, your dashboards, your websites, try to synchronize and harmonize with other organizations that are active in the field. Think about ECDC, think about EMA, think about ESCMID, think about all the other organizations. If there's one thing that Europe suffers from, it's over-administration, over-regulation, too many pages. And, healthcare providers are like clinicians, like politicians. They like to read, but they don't like to turn pages, if you know what I mean. So keep it short, stupid and simple, and synchronize it at European level. The second advice is try to get it into European regulations on the European agenda. Europe, whether we like it or not, is playing an increasingly important role in healthcare in many different fields. We know that healthcare is still a national competence, but Europe has the right to intervene where they are complementary to national competencies. And so we see this in all different fields. We see this from the MDR, the IVDR, the Artificial Intelligence Act, the Critical Medicines Alliance, HERA, GDPR, you name it. Europe is increasingly important in healthcare. So try to find a way to put AMR, the narrative of AMR, at a European level. Put it into quality. Quality is an increasing thing that Europe is being involved in. Try to get it into resilience. Resilience of healthcare is flavor of the month in Europe. Healthcare systems being prepared for shocks. Make AMR a part of that narrative. And that is my last advice, also make sure that AMR is a narrative that touches the public, because the public motivates politicians, and politicians motivate how healthcare systems reimbursement are organized and how advice is being followed or not followed. So make it a public narrative. It's been on the agenda a couple of years ago. It's again going down. How to make AMR again a national public priority is going to be extremely important and something I think this alliance should be working on. So that would be my advice.
Thank you very much. Thank you again. I'm thinking to the very nice session of yesterday about communication, how much antimicrobial resistance could be included also in experience or initiatives for public. So thank you very much. The floor to Camelia. You have.
Yeah, I would just like to pick in for an analogy on what I already heard here. Don't preach to the converted. So let's talk a little bit about those converted people, the converted people who are reading the Bible. We are the converted people and the Bible. We all know the Bible. You have the apostles, you have Lucas and John and all the other. One thing about that, the Bible is the same. Stayed the same during the last 2,000 years or more. So if you would compare that to WHO, to ECDC, to local Cienzano, Babcock, other people who are making guidelines, ESCMID, EU-JAMRAI, these are all apostles which are publishing, still publishing and producing materials. And the converted people don't have time to read them during their work hours. They mostly read them in the evening or early in the morning, or on Sunday instead of the Bible, I don't know. But yeah, I mean, what you said, it's really like important, and don't take it as a future something to try to synchronize these references and these sources of information. Try to do it like from Monday on, Monday now, 2nd of February. Try to make a team to synchronize ECDC and WHO and EU-JAMRAI published materials. I mean, they all have their graphic teams, then they all have their writing teams. Let's make one channel of information so that the converted people has only one Bible to read. And not all the versions, and because we are not able to keep up. I mean, I appreciate immensely every materials that you make in EU-JAMRAI. I appreciate a lot the ECDC materials. I just don't find the hours and the time to keep myself updated with everything that it's published on those websites. If it would be one, it would be manageable.
Thank you, Camelia. So again, from Kette, from papers, guidelines to practice, your opinion.
I would like to continue where I ended before, because, I talked about that we saw big challenges with rings and long nails. And when we presented the results from the countries, the participants, we involved them from the beginning. We said, how can we solve this problem? And they didn't say, we would like to have some guidelines. They didn't say that. Instead, the solution of this was that we made posters. We made, you would probably say, Johan, dumb posters, simple posters. We made one poster like this with a drawing of a hand with jewels and rings and germs. Then we draw germs on them. And then they hang it up on the nursing homes. Also, another poster we made was 8 myths about gloves, because they had a awful use of gloves. Sometimes they just reuse the gloves. They hand sanitized their gloves, or they put on 2 gloves just to be sure. So we made a poster, 8 myths about gloves, telling that this is not the way, because you think you're more safe when you use 2 gloves. You're not. You cannot be completely sure that there are no holes in your gloves and so on. Anyway, so that was what the end users, they asked for. They didn't ask for guidelines. They asked just for simple communication. And also bear in mind, as I said in the beginning, we saw significant improvement in 17 out of 29 IPC practices. So actually, simple communication can be very effective, I think. Anyway, but I was now going to say something about what would I like to give as an advice or something to JAMRAI from my perspective, long-term care facilities, and I have also 3 points. I've noted that it's popular with 3 points. I have less is more, I have pedestal, and then I have time. They come in alphabetic order. And less is more. It's because that in the Imagine, the intervention, the main intervention, was a 2-day physical workshop. Quite huge to collect in each country so many nursing home staff for a 2-day physical intervention. Quite huge. Less is more, because in Denmark, where I come from, we've done 2 projects where we did the same, but we did 2-hour workshop, not 2-day, 2-hour workshop for the nursing home staff. And the results of the 2-hour working shop, which was about IPC and antibiotic, was that we saw a reduction, a 50% reduction in the use of antibiotic. And one of them was a randomized controlled trial, and there was no more residents who died or was hospitalized, so it was effective. 2 hours could do, and that is maybe my advice for JAMRAI. Maybe sometimes consider that less is more. All right? The second, pedestal. I talk in the context of long-term care facilities and nursing home staff. They don't know how important they are. You know, they are the frontliners, and they are the first one to see the changes at the residents. They know the resident best. So it's so important to tell them how important they are in relation to prevent infections, and also not to call the doctor for antibiotic. But often you hear them say, well, AMR, that's not my problem because I'm not the one who prescribes antibiotic. That's what they say, and then they lean back to our workshops and, well, it doesn't really. But then we tell them, you are so important because you can prevent the infections. And bear in mind that UTI is actually preventable. And it's the most common infection among elderly. But it is preventable. It's of course difficult when it's older people, but it's preventable. Thank you. That was the pedestal. Up with the end users on the pedestal. They are so important. Finally, the last, and that's a cliche. I know it's a cliche. It's time. But the project I've done, when I look at the project I've done, there is a clear correlation between the time, the amount of time that I have put in the project and the success. And I know, so my hope is that you will put time, heart and soul in the project, because that's sometimes worth it. I know we are all busy people and you compete with other projects and you have so many things to do, but time is really the most important thing also if you want to achieve results. And I heard the first day when I was here, I heard several times that we have budget. So you have budget, so I also think you should have time. Thank you.
Thank you very much. Thank you very much. The floor to Pilar for her intervention. Yes.
Thank you. Thank you very much. From the point of view of primary care professionals, and particularly family doctors, we need to ensure sustainability along the time to have impactful health outcomes. And we need to encourage the work of JAMRAI in 3 lines. To continue to translate UE-level antimicrobial stewardship policies into realistic and implementable actions in primary care. They need to get involved into the fabric of multidisciplinary education, both undergraduate and postgraduate health professionals, to optimize awareness on infection prevention and control and antimicrobial stewardships. We need to meet primary care teams where they actually work in the digital clinical workflow. My advice is threefold. 1, information overload to avoid it. Move away from long reports, as Camelia mentioned. Instead, use push-up or brief clinical alerts integrated into electronic health records where we make decisions. Second, a cascade model. Use the national member organizations of primary care and family doctors as the World Organization of Family Doctors and their member associations, because we trust family doctors, and with programs as JAMRAI peer-to-peer program or the IPC Nurse Corner for primary care teams, the adoption rate will significantly increase, and then this model top-down will expand in European area, and introduce, as you are doing, new training tools to sense-making the way we are implementing IPC and AMS. Gamification and visuals as the art project or memes strategy to make visible in the waiting room, in a staff lounge, in primary care facilities in Europe. Communication is also very important, performing it multidisciplinary, message for the doctor, for the nurse, for the pharmacist, reinforcing that we are a single unit of a stewardship, and also involving patients and civil society. I envision an impact that moves from defensive medicine we are sometimes practicing due to time constraints to confident stewardships. For the professionally represent JAMRAI 2 activities will provide a kind of safety net we currently need by accessing to peer-to-peer mentorship, behavioral science toolkit you are providing, family doctors and nurses will feel psychological support when they choose to prescribe or not to prescribe antibiotic in daily basis. So that means add a support or address clinical uncertainty in time of constraints through better access to rapid diagnosis tests and clear protocols for conditions, non-complicated infectious diseases, as well as reducing the environmental impact, and finally empower patients because unified European-wide communication will have already made citizens aware of antibiotic safe use before they even enter our consultation room. So I think this panel has shown the antimicrobial stewardship is a team sport, from the Hospital Alliance to the primary care facility to the suppliers. We are all part of the same team with the aim to improve people and planet health. And when we protect the effectiveness of an antibiotic, we are protecting one health for the future. And that's what family doctors are transmitting in every daily consultation as much as possible. Thank you.
Thank you very much. It's now finished our time. The timer is really judging us in a very serious way. So I'm very, very happy, and I would like to thank all the panelists and also you for the attention. I think that there were a lot of inspiration, suggestions, something to reflect also in the future. I think that for JAMRAI there is a very huge work to do, and I try to summarize from a I'm very happy for the practical vision, for the end user's vision. I think that inviting here end user panelists is successful, is really a good idea, because they inspire for asking simple communication, pragmatic tools, not so many guidelines and papers, but something practical. And I would like also, finally, to thank Diamantis, because give me the chance to close this session with the inspiration vision of synergy. And this is a big value, especially for Europe in this moment. I think that synergy and cooperation is our strength. So thank you very much for reminding us this very important framework in which to work together. And I think that this is an example of synergy and cooperation that is productive. So thank you very much for the attention to everybody.
Yes, thank you. Thank you very much to all of you. And, you know, as head of microbiology and IPC department, I had the impression to be in my hospital because we had always this sort of discussion, and I agree, fully agree with what you said with routinely problem of access of IPC, of the work of IPC nurses, etc., and also the willingness of hospital managers. I can talk about that during one day. So now we have the coffee break. We still have behind me the info corners on awareness, country engagement, IPC and antibiotic stewardship. So please do not hesitate to visit them. Another information, so today the coffee and the lunch will be only on that level, not upstairs. And also we still have stickers and the sketching AMR book. So do not hesitate to take stickers, and that will be excellent gift to your colleagues when you come back home and you have seen that they are very cool on the computer. And so if you haven't done yet, please take a book. And when you come back, please can you sit in the room, not on the stairs, and use the middle of the room. Thank you. We have to back at 11:05.
Okay, I was one.
Please, can you go back? We are already late. Please, can you go back and sit in the middle of the room, not on the stairs? Thank you. We are already late and you all have flights to come back home. So please. Yes. So thank you. Please take a seat. You will have other opportunity to discuss at lunch. Finally, I should learn the word take a seat in the 30 languages of the joint action. Maybe it will be more efficient. So thank you for coming back. We will start with the next roundtable on animal health. Everybody is sitting, okay. On animal health, and I call first Lucy Colino will be the moderator, and Maria. So please, thank you.
So, good morning, everybody. Thank you for staying with us for this panel. I'm Maria Vilar, working at the Spanish Agency for Medicines and Medical Devices, and I'm here with my colleague.
So, good morning, everyone. My name is Lucie Colino. I work at ANSES, the French Food Safety Agency, and I'm co-leading the work package on surveillance, and especially the ESVET network for AMR surveillance in veterinary medicine.
Thank Thank you. So we are going to have now an open dialogue with our stakeholders in the animal health sector. We will focus on AMS, IPC, and surveillance, as Lucy. And one of the objectives, if not the main objective, is to have an open dialogue with them and get their feedback, advice, and discussion on the implementation strategies we want to carry out within JAMRAI, but also trying to discuss about the potential synergies or the synergies we have between JAMRAI outputs and the actions they are carry out in their institutions. So with that, sorry. Yeah. and with that, we are welcoming our panelists to the stage. So we have Anna, Ernesto, Dora, and Claire. Please, welcome. And maybe we can. So we have Anna Mateus. She's a veterinarian by training, and she works as a senior scientific coordinator in the veterinary products and drug resistance at the World Organization for Animal Health, WHOA. She's responsible for providing the secretariat for the WHOA AMR working group, and is a technical focal point for the quadripartite joint secretariat on AMR. We also have Dora. She's also a veterinarian by training, and she works at the United Nations Regional Officer for Europe and Central Asia, based in Budapest, Hungary. And her current responsibilities at FAO include supporting projects at Eastern Europe and Central Asia that 8 countries in developing and implementing their national action plans on AMR. Welcome.
And I'm introducing, it's my real pleasure to welcome Ernesto Liebana. He's also a veterinarian by training, and since 2007, he has worked at the European Food Safety Authority, and is currently leading the biological hazards team. In addition, he was recently appointed as the lead of the interagency AMR working group, so he will also tell us more about the role of this group. So thanks, Ernesto, for being with us today. And our last panelist is Claire Carlyle. She leads the secretariat of the European Platform for the Responsible Use of Medicines in Animals, so-called EPRUMA. Claire is also the communication director at Animal Health Europe and communications lead on other multi-stakeholder platforms, including European Livestock Voice and Pet Islands Europe. So thank you, Claire, for being with us.
So let's start with our first question to Dora, and it's about how the JAMRAI outputs we are producing in animal health sector can complement FAO activities to tackle AMR.
Well, thank you very much for the question. And also I'd like to start with saying thank you for the organizers for inviting me to join this panel, but also to be part of this meeting. I can say that it has been very inspiring to listening to all the talks and to see all the achievements of the EU-JAMRAI. There are really, really great achievements, so I really enjoyed being here. And so for the purpose to answer your question, I need to give a little bit of background of what we are doing at FAO. I hope you don't mind. So at FAO, we are particularly working in low and middle income countries all over the world. But I am representing today the Regional Office for Europe and Central Asia. And from this office, we are working, as it was mentioned, particularly in Eastern Europe and Central Asia and the Caucasus. And when it comes to the field of AMR, we are supporting countries in developing and implementing their national action plans on AMR, focusing on the actors in the food and agriculture sector. So we are mainly collaborating with the animal health and food safety and plant health authorities, the farmers, the veterinarians, and also the animal health laboratories. So they are the main counterparts that we are working within the countries. And we are working with them in various aspects of antimicrobial resistance. So we are trying to build capacity in these countries for them to conduct AMR surveillance, We are also providing trainings for the veterinarians and the farmers on prudent antimicrobial use, but also on other good practices that can help to reduce the need for antimicrobials. We are also working with veterinary faculties in the region to improve the curriculum of veterinary students. Yeah, and we are also doing a lot of awareness raising. So these are our activities in a nutshell. And I can say that the EU countries always serve as a best practice example in our work. So whenever we are providing trainings and giving advices to the countries, we always follow the EU guidance and the EU examples, and it is very useful, especially for those countries in the region that are aiming to become part of the EU. And for some concrete examples, as I was listening to the talks in the last few days, I'd like to highlight two things that I found really, really interesting and also particularly useful in our work. One was the country examples about the activities to improve the accessibility of antibiotics. I really liked these practical examples and the approaches that you had. So this is for sure something that we will also use in our work, because the accessibility of drugs is also an issue in our countries. And then the other thing, I am really looking forward to see the antimicrobial stewardship guidelines for the veterinary sector that you were mentioning yesterday, that are going to be published quite soon, because I'm pretty sure these will also be very helpful for our counterparts. Of course, they may need to be adapted to our context and to our country's context, but I'm sure we have a lot of overlapping issues. So yeah, I will not take more time. Thank you.
Thank you, and I think we are all expecting to have this collaboration with you. And our next question is to Anna, and it's a similar question, but what synergies do you see between HUA strategy and on AMR and prudent use antimicrobials and JAMRAI deliverables we are producing?
Thank you so much. Okay, I'm starting. I do a collection. I always have this issue. But thank you so much for the opportunity and for me to be here today on behalf of the World Organization for Animal Health. We really are following very closely what JAMRAI is doing, because it's so inspiring and so motivating to see the deliverables that you're preparing, and the progress since last year's meeting has been amazing. And I was only here yesterday, but I was really impressed. So I can see a lot of synergies between what the deliverables of JAMRAI and also our AMR strategy. As just a reminder, WOA is an intergovernmental organization, and we are responsible for setting up the international standards for animal health and welfare. And we have 183 members across 5 regions. So actually there's the opportunity for globalization and increasing the impact of the reach out of your deliverables. Actually is very well aligned with our 4 pillars of our AMR strategy. So our first one is on raising awareness and understanding of AMR. I think the work, for instance, that your comms team is doing is amazing. We first had the launch of the video for veterinary services, our general session last year. And it went into the veterinary services, but also the chief veterinary officers that are at the general session. And they were really impressed, and everybody wanted the pin. So we made everybody wear the pin. And then we went last year, we also went to Brazil. So during the summer, with the comms team and the World Small Animal Veterinary Association, we developed the videos and the postcards with the pin for the Congress in Rio de Janeiro, in Brazil. And this was really aligning it with our own standards, but also with VSAVA's recommendations for veterinarians in practice. And working with companion animals is really a different ballgame, because they're not covered by veterinary services, and it's all private sector. So it's really difficult for us, and you have also the pet owners. So it's a totally different ballgame because we're also dealing with vaccine hesitancy and people having very odd beliefs and behaviors. So in that Congress, we reached out to, we had 5,000 veterinary staff and private stakeholders working in companion animals. And we distributed, this was a pilot, so we distributed 2,000 pins and materials and the videos between us and Vasava. So it was quite impressive, and people were so recognizing and so happy to have materials to disseminate to pet owners because they're seeing a lot of antimicrobial resistance in the Americas region, particularly in South America and Central America, but they don't have the resources or the tools to educate companion animals. They see a lot of bad behaviors like getting antimicrobials without with the prescription of veterinarians, and they are dealing with a lot of multi-drug resistance and off-label use of carbapenems and other highest priority critically important antimicrobials. So that's one, and we continue to work with the comms team because this is a great collaboration. At the same time, we are also working on doing antimicrobial stewardship concept. So our working group has come up with a definition for consideration, but of course it's not adopted by our members yet, but we would like to, we have raised it as well with you, and is thinking about antimicrobial stewardship as the commitment for preserving antimicrobial effectiveness by creating and sustaining conditions where antimicrobials are not needed and where use is necessary, optimizing use to ensure maximum effectiveness when you have to use them, and reducing the risk for resistance within a culture of continuous improvement. So we're really looking forward for your guidance on antimicrobial stewardship, because then we can try and see how we can continue to work towards antimicrobial stewardship concept, developing that together with you, so we don't duplicate the work and we don't confuse our membership. Because we already have differences between regions and we need to make sure that we all align. So, or else the membership doesn't uptake the recommendations. It's really a problem. And I think that would be great to have that. And we're also focusing on disease prevention and control, for which we also looking very, very much to your IPC and biosecurity measures. WHO has a list of priority diseases that we're currently revising to try and improve the uptake of vaccines. This was following the Animal Health Forum that we had at the last general session, but also following the UNGA Political Declaration for Antimicrobial Resistance that came out in September 2024. And also very importantly, I would like to say that we, from our ANIMUSE data, which is from our global antimicrobial use database for animals, we know that having training for biosecurity actually helps reduce antimicrobial use. So if we have the evidence, the data, we can actually see the impact of the interventions. So we have that for New Caledonia. They did training for biosecurity against African swine fever for the outbreaks that are going on globally. And actually the side effect of it was a reduction of 44% on use of medicated feed in pigs. So they were really happy, so we have that kind of thing. So we're trying to get as much case success stories from our membership to try and show the evidence, because the problem is, like yesterday the key speech was done, is we need more evidence from the animal health sector to make sure that then everybody sees it. And we have that issue at the moment. The human health, they have that evidence from the GRAM study, but we're missing that. And that leads me to the ears vet, which I think is really important, because that will help us to have an idea of the burden of animal disease associated to antimicrobial resistance. We really, and particularly related to animal pathogens, we really need that evidence to be able to convince politicians. And it's very aligned with our standards. We currently revising Chapter 6.8 of the Terrestrial Animal Health Code, which is focused on harmonization of surveillance in antimicrobial resistance in animals. And we need to be able to harmonize the data between our sectors, because there's a lack of that, but also to be able to compare what other sectors are doing, and then across countries as well. So we really need that data, and we really look forward to see what's coming out from your project. So thank you so much.
Thank you, Anna, for very explaining a lot of things in common and where we can collaborate. So our next question is now to Claire, and it's about how can EPRUMA use JAMRAI outputs on AMS and IPC frameworks or guidelines to enhance the optimal use of antimicrobials. And I pass.
Thank you. My feelings of imposter syndrome are raging right now, because not only am I not a veterinarian, but I imagine that many of you have never heard of EPRUMA. So I'll just start by explaining what EPRUMA is. So it's a platform, a multi-stakeholder platform that was set up in 2005 by Animal Health Europe, the association that I work for as the day job. So that's the veterinary medicines producers, FEE, who I know is here in the room, the veterinarians, and Copa Cogeca, so the farmers and agri-cooperatives. And it was based on an existing platform that was set up in the UK called RUMA, and they focused on responsible use of medicines in agriculture only. We wanted to look wider at the use of medicines in animals in general. And we quickly grew to have, I can't remember how many it is off the top of my head, but I think it's 12 members. So we include also producers of diagnostics, the biosecurity people, the breeders, the feed people, the small animal vets, and many more, I'm sure. And we also have associate partners in national platforms. And so within our network, I think what we can do, certainly with the JAMRAI outputs, is really spread that within our networks, because we have direct access to the veterinary associations, to the farmer associations, so directly to the people on the ground who are prescribing antibiotics and using antibiotics. This is something that we do on a regular basis. We've always supported projects such as Innovad, such as Disarm, Project Roadmap. There have been so many over the years since we first started. And it's something that we do very often. So EPRUMA is a member of the EU One Health platform on AMR. So we attend those meetings, and again, we will raise awareness on the outputs of JAMRAI on our own work through the years as well. But in a second instance, at a meeting last week of our partners, we agreed that the best practice framework that we set up, so EPRUMA has its own best practice frameworks, which is not really about, well, it is about stewardship in the sense of setting the scene for responsible use of medicines. So we have guidelines for antibiotics, anthelmintics, vaccines, and then more recently we have parasite control products in pets. We also have fact sheets on responsible disposal of medicines, and we're currently working on fact sheets on biosecurity and on online sales, so how to identify if it's a valid seller of antibiotics and the need for a prescription. But we don't only focus on antibiotics, as you've heard here, so we really want to make it a very holistic program, and we are going to be reviewing our best practice framework, so definitely the outputs from JAMRAI will serve for that. We will definitely look at those. We need to update it in line with Regulation 2019-6 on veterinary medicines, so that is quite a mammoth task, but it's something that we'll be taking on this year. But one thing I will say, as you heard me mention, we have recently developed guidelines on parasiticide use in pets. We don't have guidelines, we don't have any best practice framework for antibiotic use in pets. We have, over the years, done some minor communications on, responsible use, responsible disposal of antibiotics in pets, but we don't have a sort of set framework for that. So that's something certainly we can glean from the JAMRAI outputs. But for us, surveillance and data are also very critical issues. So we were really pleased to hear earlier this week that the EARSvet report will soon be published. So this is typically something that we will pick up, glean some key information from that and share via our networks. And I know there were questions about the sustainability of that, so I would make a plea to our commission people who are looking at their computers to please give the mandate to EFSA for that. We fully agree that this would be a good body to take over the EARSvet, so hint, hint. And then just, there are other work packages, of course, that are important for EPRUMA, for particularly on access. So over the years, EPRUMA It's a communications and a policy platform. So we get involved in the consultations on EU regulations, on policy, particularly a couple of years ago on the priority list for antimicrobials, because for us it was important that animals retained access to the key antibiotics that they still need. Of course, human health is a priority, but animals, need access to medicines too. So that's definitely a work package that we're also very much interested in, because we need to make sure that we can continue to bring veterinary medicines to market and, of course, increase access to vaccines to increase the prevention side of things.
Okay, thank you. Now let's go to ask for more practical advice from you. And I would like to ask Dora about what factors you think will make IPC and AMS an effective instrument rather than a constraint in the future of farms and veterinary medicine. I'm talking about sustainability of that implementation.
Thank you. It's difficult to say something that hasn't been said already in the past 2 days. So I'm going to highlight first 2 things that I think are really important, but has been mentioned, of course, in the past speeches. One is, I think, is the economic aspect of the intervention. So for the farmers, livestock farming is the income. So whatever we try to make them do, I think it's very important to show them that this will also come with an economic benefit. So we need to show them that if they improve IPC practices, if they improve husbandry practices, nutrition, they can eventually improve productivity, and they can reduce the use of antimicrobials, they can save some costs there, so at the end it can be beneficial for their how to say it, let's say for their business, let's say. So I think it's really important, and the government, the support of the government, different funds and incentives can be very useful in this aspect. Another thing I think is really important and has been already said is integrating behavioral science approaches into the interventions that we design to improve IPC and antimicrobial stewardship practices, and really to try to understand what are the factors that are influencing the behaviors that we would like to change. Like, just to give an example from the countries where we work with, it is very common that the farmers can and do buy antibiotics without a prescription from the veterinarians. And we all know that it's an issue, but in many cases this is not because of they don't know that they should consult a vet, or they don't want to consult a vet, or there are no regulations that they need to have a prescription, but instead it comes from the difficulty to access veterinary services in some remote rural areas. So this is a problem that we cannot simply solve by educating the farmers, because the problem might not be that they don't know what they should be do ideally, but instead we need to look at it at a broader context. And the third point that I'd like to make very briefly is about focusing on also the young people. So not only the farmers and the veterinarians, but also the undergraduate students, like the undergraduate veterinary students, to kind of shift their mindset to already start practicing with these new, let's say, new trends in their mind, and so that IPC and antimicrobial stewardship is really integrated in how they start to work as a veterinarian from the very first day after graduation. And I believe that if they graduate from veterinary school with that mindset, it can be really helpful to make these interventions work and be sustainable on the long run. Thanks.
Great, thank you. Following up that question, we would like to hear from Hua how you can complement also this question about sustainability of implementation, like which are the incentives or enable conditions from your point of view that most effectively can support implementation of EU-JAMRAI produced frameworks.
Thank you so much for your question. That's really interesting. So similar to FAO, first we need to have the buy-in from politicians. And I'm not only saying European Commission, but it's really very important to have that AMR prioritized in the political agenda. Everybody is very distracted at the moment because we are facing very complicated geopolitical situations globally, and we need to make sure. So we have the EU region as being one of the leaders in AMR because there's really a buy-in from the European Union, the community, to deal with it, and it's been shown for many years. And time again, the EU has proven that it's committed to lead by example. And it's not only JAMRAI, for us, also we have had to receive funding from the EU to do projects in the Americas region from several countries, and also in the Asian Pacific region, we just finished a large project. So now we are gathering also funding to try and continue these activities that we first started. It's like the planting seed for us to start doing more and more work with AMR in the regions, particularly because in many of these regions, they are hotspots for AMR, and we cannot think that we are living in a contained region. We have international travel, we have international movement of people and animals and food, and therefore we need always to be thinking about this as a global issue, not just a regional issue. And when we think, for instance, at the quadripartite data from TRACS, which is the self-assessment that countries have to do in terms of monitoring the implementation of the national action plans, we have 177 members across the 4 organizations that say that they have multi-sectoral national action plans, but actually only 20% of those are actually putting funding for the implementation of the national action plans. So it looks nice in paper, but it's not really going very far away. And usually the issue is also saying there's no action. There's the national action plan, but there's no really action there. So that's what we have. So that means then that any frameworks that you have on IPC or on microbial stewardship are not being implemented. And we're not seeing any results, and the issues remain. So it's really important as well, as was said before, that we need to have a kind of assessment of the impact of interventions, but it's not only in terms of reduction of antimicrobial use, but also in terms of animal health indicators, impacts, welfare, and then also economic impact, because that's very important for members. How is that going to affect our livelihoods of farmers, as Efie was mentioned, but also the GDP, and the productivity, and the international trade opportunities. That's also very important. So one of the things that we're trying to say is, for instance, that we should be working and looking as well for potential funders that are not always public, but also considering private sector as resource partners, and also establishing public-private partnerships to see how we can collaborate together, explore the synergies, because, for instance, there's a lot of large companies that have integrated production systems that can lead by example. And for instance, on the veterinary sector and companion animals, we see that we have more global corporate veterinary practices that also have IPC, they also have antimicrobial stewardship, and they also have their own programs. So it's important that we ensure that because they can help us also to implement in the field these kind of practices. So we have the veterinary services and then all the private sector we have to address. And then, of course, we need also to do campaigns for awareness, not only targeting the usual suspects, which are veterinarians, veterinary services, but also animal owners, children at school age, or undergraduates across human medicine, veterinary medicine. And I really love what you've done with arts, like the exhibition last night, because it's a different way of reaching out. And I know probably the youth group, for instance, from the quadripartite, they do a lot of activities. There's things about doing media. For instance, I'm totally useless in TikTok videos, but apparently that's the big thing in many countries. So that's how things are trying to move at the moment. And we also, very important to make sure that, that we can doing, I mentioned before the complicated geopolitical situation, but we have the UNGA political declaration. And 193 UN members have signed it. So we really need to build on that. And I think your deliverables are very aligned with those, because for the general commitments, but also for the 4 main specific for animal health, which are mainly reduction of antimicrobial use in food production systems, the other one, optimization of antimicrobial use in animals and agriculture, we have also a big focus on disease prevention and as well improving access to quality veterinary services, but also quality medicines that are affordable and are quality. And from the medicines, you have not only antimicrobials, you have also other veterinary products like alternatives to antimicrobials, vaccines, and diagnostics, because we tend to miss that you cannot do a good antimicrobial selection or treatment selection if you don't have good diagnostics available. And I'll stop there. Thank you so much.
Thank you. You have been giving us a very nice overview of what is needed, both of you, from FAO and WHO point of view. Let's move to Claire and ask, I would like to ask her how we can work together to ensure that the stewardship and responsible use of antibiotics is administered through those using veterinary antibiotics. Thank you.
Yes, thank you. So indeed, as I mentioned, as a multi-stakeholder platform, obviously we have access to a wide network of those who are directly prescribing and using the antibiotics. So all of the outputs, everything can be converted by us into messaging when we're speaking to those people, particularly the farming groups. There are many trainings adapted nationally for farmers on responsible use of antibiotics, on holistic animal care, so there's a reduced need for antibiotics. And I would like to call out in particular one, it's not under the Apruma umbrella, but it's run by FEE right now. So they are running training sessions for farmers and veterinarians together in all of the member states. So raising awareness, training on AMR, training on the application of the new rules on veterinary medicines, and this is absolutely crucial. This is something that I think we should all be doing, and I understand that it requires a lot of financing, a lot of budget, but this is how we get the message to those people on the ground, you know, who need to know more about responsible use of antibiotics. But on top of that, I mentioned the national platforms that we have as associate members. Now, two of these are from the UK, but we also have Belgium. I saw AMCRA here in the room, and we have the Netherlands and Spain, and they are extremely active on using the outputs from these different programs and converting them into training sessions, into awareness campaigns. I mean, I was really gobsmacked by the fact that this little pin is being picked up by the BBC. I said to the comms people, this is such an achievement. As a comms person myself, when I saw this campaign launching for the symbol, I was like, oh, that's a really nice idea. I hope it takes off. And now we're seeing, I saw Emmanuel Souberan wearing it. I've seen, you know, all the leaders of these associations wearing this pin. And this is exactly, if that's the only thing that comes out of JAMRAI, then, you know, that's a huge achievement. We want that to be as well known as the AIDS ribbon, as was said yesterday. So that's definitely something that we can help. Our purpose is to serve as a multiplier. So my message to JAMRAI would be, please use us. We are obviously on the stakeholder group, so please use us. Please ensure that we get all the materials that you're producing. And then also, you know, we are direct members via FEE, via Access VetMed as well. So we're very much involved in the co-creation in some of the work packages. And I think this is really important. The fact that we created guidelines, a best practice framework together with the farmers and the veterinarians means that it's actually applicable on the field, so to speak. So it really is something that they can use, because obviously policy is great, and I think we do need to have rules, and it's great that we now have prescription EU-wide. But it does have to be applicable, it does have to be feasible. Those of you who live in Brussels or Strasbourg or even other countries will have seen farmers out in the street protesting because they are overburdened with admin stuff. They feel that they're always blamed for destroying the planet, and they have had fingers pointed at them for overusing antibiotics as well. So we need to produce positive communications, guide them, help with financing. We're hearing that the cap is, you know, being reduced. So all of these things need to be taken into account. It's not just about guidelines, as the medical doctor said earlier. It really is, we have to help those, give them access to the human resources that they need, to the financing that they need, to veterinary capacity. We have a lack of veterinarians, particularly large animal veterinarians, and this is something that needs to be seriously looked at, especially as we are going to a more preparedness approach in the EU. Animal health is part of that preparedness, and disease prevention is a key part of that preparedness.
Thank you for your input. So I pass the word to
Thanks.
Lucy.
I will continue and help out as well. So during this General Assembly, we also provided an update on our progress with developing EARSVET, which is a network for AMR surveillance in animal pathogens. So my question goes to Ernesto. In your view, Ernesto, could you share with us your ideas on how you think EARSVET could complement and be integrated in the future in the ecosystem of existing AMR surveillance programs in Europe, including the one run by EFSA?
Thank you, Lucy, and hello, everybody. I would like to say two quick things before jumping into the question. The first one is I'm really grateful for JAMRAI to have invited EFSA again to this stakeholder forum for the second time. I was not so happy in JAMRAI 1, and I made a couple of points because I didn't really see the One Health other than in the title. I see that there has been a massive change in mentality, a huge jump in efforts, and I truly believe that this is now working. I think all the environmental compartment activities, what you have done with EARSVET is really commendable, so I can see that, that this is really a good thing. Then, because I represent EFSA, and EFSA has in its title Food Safety Authority, it's not immediately evident for people that we also have a mandate on animal health. And there is an animal health and welfare panel that provides a lot of advice to the risk managers in Europe. But this has been traditionally on the topics different from AMR. And I think the history of advice on AMR and animal health is very short. I can go back around 10 years when, together with our colleagues in EMA, we produced what for us is the Bible, this RONAFA report. It took us over a year, and it ended up with very concrete and nice recommendations around 3 topics: reducing, replacing, and rethinking. Reducing the use of antimicrobials in animals, and it was basically by bringing very prominently this issue of setting targets. Then the targets went into European legislation, and we are progressing very well in the animal sector towards meeting the targets in reduction. The rethinking, which has always been, the replacing, that has always been a challenge, and in which EFSA is also quite often involved. We are the recipients of applications for new feed additives, and companies are very interested, but it's not so simple for them to understand how to make it possible. And then the rethinking is where, especially in the animal welfare area, this AHAO panel that I mentioned has done a massive amount of work to try to improve the way our animals are treated and raised so that they need less antibiotics in their production systems. So that was the first thing that was done in this front. Then, more recently, we received a number of mandates from Santé. One was to come up with priority combinations of animal pathogens and antimicrobials, and that was quite successful. There was an opinion for each major species and also for pets, and I think that has been picked up by also EARSVET in considering what should be surveyed for. But then there was a second question, and it was about applying the criteria which are listed in the animal health law to see if any of those combinations would make it to the list that mandates the performance of EU-wide surveillance. And the answer to that was in most cases uncertain, meaning that there was no good reason for the risk managers to add this to that list. And that was the end of the story. So I think in your question, I have to separate what is scientifically interesting, and you explained it very well when you did the update the first day of the meeting on EARSVET. I think it's quite clearly there is a gap. We don't have data from sick animals. We don't have data at the European level in a harmonized way for pets. And this is something that would be immensely helpful when you're trying to do antimicrobial guidelines, when you're trying to correlate the level of use with the impact on seeing how this reduction also has a positive influence in seeing less resistant pathogens. We do it with a proxy, which are our indicator E. coli, and that is showing already that the progress is there, but it would be very nice also to have the indication that this is truly happening with the bacteria which are making animals sick. And therefore, in my view, really important also if you want to monitor any type of intervention directly, because otherwise you're always linked to a proxy. So as you heard, EFSA is very active and 4 years has been coordinating in Europe the production of this One Health AMR summary report, which gathers data from healthy animals and from food-borne pathogens such as Salmonella, Campylobacter, E. coli, and these are very useful data, and they are. It comes from the mandatory activities of the zoonosis directive. So there is a very clear written law that makes member states to perform this monitoring, to send the data to EFSA and end up in a report which is totally transparent and allows comparisons between countries, between sectors, and that puts a bit of peer pressure, and I think is what makes people and countries improve. So it would be a dream to end up in a situation where you would close all these gaps and end up in a complete report, or in reports which are complementary and in turn can be used also, all this data, in the comparisons that we do, the correlation analysis done in JAMRAI with our colleagues in the human sector. So there's no doubt that scientifically this is important and relevant. Then is what is feasible and what is prioritized. That is a bit out of the hands of EFSA. It is something that we often say, and sometimes you produce scientific advice, but there are many other considerations that need to be brought into the discussion with member states and with risk managers. And we all know there are conflicting priorities and resources are limited, so there's no money for everything. I think it's highly unlikely that the animal health law will change. So my advice would be to look into other ways of first proving principle that the EARS vet report is important and convincing people that the data there can be used and have a positive impact. And then perhaps think of a way of starting via voluntary programs, I don't know, by selecting perhaps a specific combinations and proposing EU baseline surveys on particular combinations, things which may sound not too ambitious, but that I think step by step will help. And who knows, maybe in some years' time, we will be in a position to receive a mandate from our risk managers in EFSA and make this possible. In saying that, I also want to say that, of course, any data that comes from any reputable source, let it be scientific publications, reports produced by national competent authorities, all this data is used by EFSA in the risk assessment. So even if we're not in the lead of producing those or gathering those, we will be users of the data for sure. And I think, as I said, with time, with evidence, we can convince people of how important that is. And I think I would stop there. Yeah.
Excellent. Thank. So this question is about. This session is about animal health activities in the field of IPC, AMS, and surveillance. But you had another session on human activities, and we have one on environmental activities. But we say, okay, we did also to work across sector, and this is what JAMRAI is about. It's also a question we wanted to ask to Ernesto, because he was recently appointed like the head of a new European interagency AMR working group, which role is a bit to facilitate this link across sectors that we're trying to emphasize and build here in JAMRAI. So Ernesto, maybe to inspire the way we are working here also in JAMRAI. Could you explain us a little bit more about the nature of this interagency working group and what are the scope and the mandate that you are trying to achieve? Thank you.
Sure, thank you. And yes, my role is a bit less pretentious as the one you mentioned. I'm just the chair of that group for the first 18 months. It's a new group, and I have to thank also our colleagues from A1, One Health Sante. I think it came from the council recommendations, and it was obvious that we needed to have all the right partners around the table in discussing also at agency level. We have a long history of collaborating with ECDC and with EMA, but it was almost unknown for EA, the European Environment Agency, and ECHA, totally newcomer in the area of resistance, what they were doing and what we are doing. So a few months ago, we received all the agencies a mandate to establish this working group. And we have on our table now a number of tasks and responsibilities. One of the most important ones, in my view, is to early on be able to discuss the terms of reference for new mandates. And we learned the hard way. There was a recent report on antifungal resistance, on azole resistance in Aspergillus fumigatus that was sent to all the agencies, and it took almost 6 months to agree on what to do, and another 3 or 4 months to get together and agree on the practical principles to deliver a single product. So that was already a learning exercise that perhaps if we would have talked about it before and have an instrument, it would have been much quicker and better. The elephant in the room, we talked about this for a long time also in these 3 days, is the integration of surveillance data. Only if we understand the different types of data each agency is gathering, we can think about whether they fit together, whether we can do something together with them. So we are starting to bring these discussions there. Of course, to coordinate on communication activities. Again, a no-brainer. You have seen the huge amount of things that JAMRAI is doing on this, and we would take good note of that and knock your door and reuse and try to make the most of what is available. We are also very often contacted by projects like yours to be on advisory boards, on stakeholder forums and things like that. And we tend to be isolated. Sometimes it's EFSA, sometimes it's EMA, sometimes it's ECDC, sometimes it's the 3 of us, sometimes it's EEA. We not often have the opportunity to coordinate, to talk each other about what we are going to say. Like we had the first meeting happened last Friday in Parma. We talked about what to say here. There was Carlin, there was Diamantis. So it is nice to come already with an idea of this. And then, last but not least, is the external engagement. So we have A1 colleagues as observers in that group, but we have also been given the freedom to involve people from WOHA, FAO, WHO, as we see fit, depending on what is in our plate. And perhaps also one of the most important things is that now there is one single point of entry for all the agencies at the same time for any issue on AMR. So if you ever need to approach the agencies for that, during these first 18 months, please contact me. Then there will be a rotating mechanism and agencies will take over each other. So that's, I think, is a very nice thing. We have a couple of people appointed per agency, and that makes communication much simpler. Also for us, because we have a more united voice with our management. We hope that we can make a difference, and with Commission by channeling a single voice. So this is a bit the vision. We just started, so be patient, but we hope it will grow into something good.
Okay, thanks. Thank you. I have another question for Dora. Dora, you know, FAO is now running an in-farm program for surveillance of AMR at international level in both healthy and diseased animals. So could you tell us a bit more how you envisage that ESVID could maybe feed ITFARM, hopefully in the future? Thank you.
Thank you. Yes. So INFARM, for those who haven't yet heard about it, is the international FAO monitoring system for AMR. And it's quite a new platform. It's a global platform for countries to collect, analyze and visualize their AMR data from livestock, aquaculture, and also food products, but also to collect data from plants about antimicrobial use. So it's a very ambitious platform, and eventually the goal of it is to provide data into what we call the GISA, the Global Integrated Surveillance System for AMR and antimicrobial use, which is being established by the quadripartite, so WHO, WOA, FAO, and also UNEP. And this Global Integrated Surveillance system is going to gather data from WHO's GLASS, which is the database for antimicrobial use and resistance data in humans. It will gather data from WOA's ANIMUSE, which is the database for antimicrobial use data in animals. It will gather data from FAO's INFARM, which, as I mentioned, will be the database for AMR data in animals and antimicrobial use data in plants, and eventually also environmental data from UNEP, which you will hear about in the next session. So the goal of the INFARM is eventually to provide data into this global integrated surveillance system and to be part of the global effort for One Health surveillance of AMR and AMU. And for the AMR data in animals, INFARM collects data from both healthy animals and also diseased animals, both terrestrial and aquatic. So it would be a great advantage if ERSVET data could be linked to INFARM, because also it would be very easy for the countries, or much easier for the countries, so they don't have to submit data twice, but we could do it between the agencies. And also just to mention that this is something that has been discussed also with EFSA. It has been a long process, but by now it has been agreed and managed that the data that is going to EFSA, the AMR data, is going to be transferred to INFARM. So I believe it's a great achievement, and also looking forward to have the same cooperation with the ERSVET. So I believe it's very important, and then eventually all this data will go to a global database to be able to see what are the global trends and to do comparisons also at the global level. Mm-hmm. Thank you.
Excellent. Thanks a lot. And maybe to complement this information, I have a final question for you, Anna. I know WOA is quite active in the field of AMR in companion animals. So could you tell us a bit more how you envisage the future landscape of surveillance of AMR in companion animals?
Thank you so much, Lucy, for the question. So we recognize the importance of the changing role of companion animals in society. We more and more treat them as family members, and this is something that's not only in the European region, but we also seeing that the growing boom and pet ownership, for instance, in the Asian Pacific region and the Americas. So our memberships are asking for us to include companion animals in our strategy. So the working group on antimicrobial resistance has validated an extension of our MR strategy to companion animals. And we have also working with quadripartite organizations to include companion animals in the revised global action plan for AMR following a One Health approach. So where members have the context in which the national context justifies it, they should include companion animals in the national surveillance systems for AMU and AMR. So that's the kind of thing that we're working on. We're also revising our standards for AMR, particularly Chapter 6.8 on harmonization of surveillance systems, looking into inclusion of companion animals. So providing guidance is a general guidance for our membership to consider how they can look at what are the relevant pathogens for companion animals and commensal bacteria, and how they should go about sampling companion animals to include in the surveillance systems. And furthermore, we're currently working with different partners on having a global situation analysis, like a report on AMR in companion animals. They should be coming out in 2027, because we recognize that most members don't have companion animals in their national action plans or in surveillance. We have a big gap of data globally on what's going on. We have scattered data from scientific studies, research, universities. They are looking at what's going on in terms of resistance. We have some very, very sporadic reports from colleagues working in practice from the Americas, as I mentioned before, saying that they're seeing multi-drug resistance in companion animals, and they're using carbapenems, and they're using last resort antimicrobials for humans in these pets. And, you know, in some of these countries in the Americas, you can get these drugs off-label. So you just go to the pharmacy and you don't need a prescription, they just buy them. So this is a very big issue that we're dealing with, and we need to try and start looking at what's happening in companion animals. But we're very happy. So some countries are really being very forthcoming. So Resapat in France, they're starting to have data, so you can see that they're monitoring ESBLs and other resistance bacteria, and we really are welcoming this kind of information. And we have the UK is also starting, it's not EU, but the UK and European region, they're also looking at companion animals. So where the data, if you have that data, it will be important, but of course you need to engage the private sector, because there is where you have the veterinary, it's not covered by veterinary service, so that we need to find system. And I'm happy to hear from yesterday's keynote speech that the electronic systems, for instance, in Portugal, they get the data from MU, but then we need to see, for instance, how do we get the data for AMR, because often that's not on the it's not easy to capture from electronic systems. So I'll stop there for the sake of time, but thank you so much.
Excellent. And so now it's time to close this session. I would like to thank all panelists for being with us today and taking the time to share their thoughts on how our JAMRAI deliverables and products can help. A few concluding remarks before we move to the next session. Well, we heard that from our external stakeholders that Europe should be, or we aim to be, at least a best practice region. So, the pressure is on our shoulders. At least I remember that external people are looking at what we're doing in terms of products and deliverables. But they're also happy to provide support. And there's three kinds of support I heard. One is implementation, the second impact, and the third one is sustainability. For implementation, we have here partners and stakeholders that have access to people working on the field, either in Europe or outside of Europe. For this implementation to happen, I think we need to have a very clear message. So we need to align our definition and guidelines to those already existing. There is no need to reinvent the wheel. And I think we also heard this from the previous session in the human sector, that that's one important message that we want to have. The second one is the feasibility. So maybe, okay, we're a best practice region, but we need things to be feasible and applicable. There are important considerations in the animal sector, like economic impact that you mentioned, I think is an important one. And for this feasibility to happen, we also need education and training. The second one, impact. There's been a lot of material developed, especially by the communication team, and I'm happy to hear that some stakeholders have already engaged into disseminating those products and making them visible, for example, the WOHA, so thanks a lot for this. I think it's important to recognize that if the Europe aims to be a best practice region, outside of Europe there is still a lot to do, especially in our animal sector, when we talk about AMS, biosecurity and so on. So we want to make sure that the products we are generating hopefully can have an impact there as well. And the third one, the sustainability, well, it's a main challenge that we have identified, we know, including especially for ESVET and our surveillance activities. And I'm glad to hear that, EFSA is willing to support us to try to find areas and how hopefully EFSA could get a mandate to try to sustain this and make sure that all the work we've been developing here, like databasing, pulling this network together, producing guidelines, like it's not going to be finished in 2027, but hopefully it can be sustained beyond JAMRAI 2, because there is a need for it. We heard this from different stakeholders, being either for risk assessment, for stewardship. There's quite a big gap on AMR in animal pathogen, and it's something that we want to further develop and hopefully sustain beyond the JAMRAI 2. Okay, so with this, I will stop here. Thanks again, everyone, for coming all the way here, and happy to collaborate again in the future. Thank you.
So let's move now directly to the third roundtable about environmental health. And the moderator will be Ricardo Carapeto. Where are you? Ricardo.
Okay. Here.
Okay.
Okay. I guess that all the panelists can sit down and then we can start, and I will introduce you as we are here. Caroline, Diamantis, Ignacio, Pablo. And there is one more panelist that... the what? I sit here. Yes. Okay. Sorry. Do you want to grab a mic? Yeah. Oh, okay. I have to say that in these situations, I hate my work because I feel very nervous in doing this kind of things. So please don't take me very seriously if I say something inappropriate. Also to the panelists. Well, my name is Ricardo Carapeto. Carapeto is a surname. It's difficult to see in Spanish, but it is a surname. I work in the 6.3 in antimicrobial stewardship in the environment, and my daily work is all about environment, medicines, and resistances. It's great to have you all here. There was another panelist we are still expecting to connect from the European Commission. Hopefully she will manage to do so while we are speaking. So as soon as she gets in, I will introduce her. But thank you all for being here. It's great to have a panel of this nature because it's very, very, very heterogeneous, the background of the people that is here. We have a civil engineer that is the one that is to be connected here. We have a physician, we have an environmental scientist, we have 2 lawyers. Could you imagine who is who? You think that?
Try to guess.
Try to guess. The lawyers are always easy to see that. No, yeah. Thank you all. I think you will all give us a very nice perspective about the topic, and I will briefly introduce you, starting with you, Pablo. Pablo is one of the lawyers. He's a One Health specialist. Sorry, but I don't see very well. Because I'm getting old. One Health specialist at the United Nations Environmental Programme. In the region of Europe and Central Asia, is it okay? And he is specialized in One Health, as his position says, and he gives support to the quadripartite in the European region. We also have Ignacio Álvarez Serrano. He's the other lawyer, as you could imagine. Ignacio has a degree on law and business, and he has been working as a lawyer in the field of environment and residues, which is a very specialized field for working, and that specialization took him to be the head, that is his actual work, the head of legal affairs in SIGRE, that is the national organization leading with their unused medicines. So thank you very much for coming. Next to him we have Caroline Wale. She is the environmental scientist. She's working in the European Environmental Agency, Copenhagen, in the unit of freshwater and marine unit. And we have collaborated in the past in AMR surveillance, etc. That is a field where the environmental agency is growing faster and faster. So thank you very much also for coming. And last but not least, you also know him because he has been already in the panel. We have here the Amantis. Placouros. So, yeah, thank you. Well, you yeah. He works in ECDC and in the AMR topics and healthcare-related infections, and he has been working for almost 15 years there in surveillance and development of guidelines. So thank you all for being here. As soon as Trudy Higgins, that is the colleague from the Commission connects, if somebody can throw me something because I cannot see you. Ah, she's there. Oh, great. Okay. Oh, Trudy, yeah. Vision is always above us. Very good to see you. Very good to see you, Trudy. And Trudy Higgins is our last panelist. She is the civil engineer working in the European Commission. She works in DG Environment in the unit of marine and environmental clean water. And she's, for her career, she has always been working in things related to water floods, store water, fresh water, drinking water, any work where water was mentioned, Trudy was there. So it's really good to have your expertise, because now she is involved in the implementation of the directive of urban wastewater that was adopted like 1 year ago, something like that. So thank you all for being here. And I have here a list of questions that we have discussed before, but before going to that, I wanted to make a brief explanation, because we are going to discuss here now about antimicrobial stewardship and surveillance, okay? In stewardship, what we have been down in JAMRAI was, as environment is one step or several steps behind humans and vets. Probably we thought that it would be better to start making kind of training to people that is related to stewardship of antimicrobials in environments, because probably many of them are not really aware of the health problem that is linked to the residues of antimicrobials. Antimicrobial stewardship is a definition that is still to be found, and we are working on that, but widely and only for the purpose of this panel, we can understand stewardship as anything that reduces the emission of residues of antibiotics to the environment, okay? So just to clarify that. So, in your view, and I wanted to start with Ignacio because of your background, which are the most urgent, important need in antimicrobial stewardship, or what do you think is still uncovered in stewardship? Yep.
Okay, thank you very much for the invitation to participate. First of all, I want to explain that SIGRE is an extended producer responsibility scheme of waste medicine in Spain. So our mission is to duly guarantee that every waste medicine is duly managed from an environmental point of view. And we have identified we can call it gaps or emergency needs that maybe EU-JAMRAI can help us to implement. First of all of us know that all the medicines, not all of them, but some of them, like antibiotics, they contain AM substances that, if they are not properly disposed of when they reach the end of their life, the environment can have this impact of these AM substances, such as soil, groundwater, or surface water. So it is important to this sense to ensure duly management of both, as Ricardo has said, unused and expired medicines in the 3 generation main points that we have identified: the industry, hospitals, and obviously at home. It is very important. This strategy must involve all the agents in this workflow. I mean, from generators of this waste, patients, technicians in health sectors, and obviously the waste managers. They have to apply best practices, the best ones, the best standards, in order to avoid these kind of substances reaching the natural environment, both urban and natural also. And obviously, the public authorities. No, in case of SIGRE, for example, we have worked very closely with the Spanish Agency of Medicines in this sense, and their support has been very important for us to communicate the importance of guarantee the management of this waste, because it is not a normal waste. It cannot be treated as normal waste. So it's important, for example, in the case of management, our system avoids, we engage managers to avoid these substances to reach landfills. We are not allowed landfill deposit because there is a minimum risk that this kind of substance reach the environment. So we take it very serious to our mission. So and the other second maybe topic that we have identified is a lack of legislation. I mean, we are lacking of at a EU level framework legislation regarding the management of waste medicines. There is a lot of legislation regarding medicines, a lot of legislation regarding waste, but not waste medicines, and they are very specific. So I think it would be a very nice point of view to have into account in other, I don't know, the meetings or debates, because it's important as well to get all the agents in this flow be part of this strategy, and I think that's everything from my side. Thank you.
No, it's a very nice introduction to the thing, and a very nice point, the one that you made with the health residues, because it is true that we don't usually think about that, assuming that everything is under control in the hospitals. But it's good to know that it's something maybe to track and to follow. How is it done? And if there's a need of making something in cooperation. Thank you. If any of you have something to add on the emission of residues to the environment, the things that you think should be covered, just go ahead. I don't know if Caroline or Pablo, you want to add something?
Do you want to go ahead? I can maybe try to add something. Yeah. So first of all, as Ignacio said, I'm here representing UNEP, which is the environmental authority globally, and yes, we're part of the quadripartite as well, and we're now working obviously on AMR with a stronger mandate, especially after our UNEA resolution this last year that gave us that mandate to fully engage in AMR work. With regards of, on the question and on stewardship, maybe to take it a bit from a broader perspective than what Ignacio was saying. I think, and it's been mentioned right throughout the days, that we're still lacking that cross-sectoral collaboration and that cross-sectoral integration. So that's a first limitation, I think, in the perspective that maybe that could bring to working on antimicrobial stewardship. There are indeed uneven regulatory frameworks when addressing antimicrobial pollution through the full cycle. So this is design, production, use, disposal, and also waste treatment. So kind of highlighting that as well. There are gaps in treatment, in the prevention, in the enforcement as well. So I think that's something that we have to look at, also linked to the regulation aspect. And tying it to probably the next topic that we'll talk about, I think there's still limited surveillance as well, still to fully understand the trends, right, and the risks to be able to define also interventions in terms of the stewardship. So maybe just to take it from a broader perspective.
Yeah. No, thank you very much. And Caroline, I don't know if you have a view or something you want to share with us. I don't want to put you in a difficult position, but just in case.
Well, maybe I should just explain. So I'm from the European Environment Agency, and our role is not as regulator. We're here to gather science and information about the environment, to help policymakers, to help our countries, and we are duly informed. It's a cycle of information. And what I was going to say is this is exactly the sort of question that makes people like me feel in the headlights. I am literally in the headlights right now, but it's, there's when I think about AMR and the environment, there's rather little knowledge in the field at all about AMR, okay, because it's not been part of the remit until very recently in the EU. And so I like to paddle a kayak, a little boat, I'm quite vulnerable to the waves. And when I look at the AMR and meetings like this, it's like that's that oil tanker and it's coming right on me, right? And I've been in this game for a while, a few years now, and thinking about it, trying to learn about it, and I know you're all trying to help me, but you come with the all the background and all this fantastic work and, you know, the kind of details that we've been talking about this morning. It's details. I'm sorry, it's not a detail, but, you know, I mean, we're starting from zero knowledge in AMR, basically. There's a bit now in the countries because of the revised water legislation, but really very little knowledge. So that the stewardship, you know, and all this, it's help the environmental colleagues, all right? And when we start talking about common things, so IPC, that's the pollution. I understand pollution control. I can talk to you about pollution control, you know. But actually, in the water area, we rely on that upstream prevention, all right. And what we feel in the water is like where it didn't work. Okay, so the monitoring there is where it didn't work. And there is actually a bit on terms of concentrations of chemicals. Under the Water Framework Directive, there's a bit of chemicals that countries need to monitor, pharmaceuticals. And that's because they're toxic to or via the aquatic environment. So there are some substances that are becoming priority substances or being monitored because of the toxicity to or via the aquatic environment. Now, AMR, there's potential there for it to come into under the watch list, under the revised Water Framework Directive, as an indicator, because we don't know what to do with the data yet. But my plea really is help the water managers now beginning to realise there's something in it. I'm sure they'll be very sympathetic if they understand what it is, how they can help, why they need to be involved, because it's another thing to monitor. We heard from the nurses how complicated everything is. This is a brand new topic to most water managers. So there's a whole bunch of stuff around, you know, and then I'm thinking, oh, stewardship, you know, what's this term? So, but it's not because it's not people aren't willing, but the whole language and all that concept we need to think about, sit down with regulators, understand where and managers, what's the common ground, because there is common ground, but it's getting into a language that people can, yeah, that's me, I can help there.
Yeah, no, I fully understand your perception. That was also my perception when I was approached. But I have to say that you have a PhD in environmental chemistry, and that is really important for stewardship. Understanding how do antibiotics behave in the environment, if there are sinks, if they are degraded, all that kind of stuff is also the knowledge of a chemist is also very valuable. So there are always points that you can find. We need a lot of knowledge from everywhere. So don't feel overwhelmed by these guys. You know a lot from other fields that are very important for us. So thank you very much. I had another question. Moving now to the surveillance part. Just to mention briefly. For surveillance in the environment, we intend to run a pilot where other colleagues in other work packages are working on that. It is a complex issue because going there and taking samples and analyzing samples is not difficult at all. But the purpose of the surveillance and what do you look for, what the frequency, the places where you take the samples, all those issues are really challenging. And one of the questions that we make ourselves several times about the surveillance in the environment is like which is the main purpose of the environmental surveillance. And here I will give you two options. None of them are strictly true. I just wanted to see your view from your position and your expertise, which would be more valuable for you. One of them, of the purpose of the environmental surveillance could be like checking the situation of the human health, like we did in the COVID, like using wastewater for checking in a given population what is in there. And the other purpose would be something wider, like going to the different parts of the environment, trying to understand the trends of the emitted resistances, the dynamics and the interactions between the different environmental compartments, between humans and animals and the environment, etc. From those two potential uses of the surveillance, what do you think of each one of them? And as I'm looking to Diamantis, I will start with you and then maybe with Trudy online. Thank you.
Sure. Thank you very much, Ricardo. I think these are key questions. And I would start from saying that we need to look at the research questions or public health questions that we are asking surveillance to answer for us. And these two options you mentioned have two completely different purposes. So the purpose of surveillance in environmental samples has mostly the purpose to identify risks from exposure to these, for example, in surface waters, right? While surveillance in wastewater has mostly a different public health purpose to probably monitor the spread or monitor the trends in surveillance in the population that is, behind this wastewater that is analyzed, right? So, but this is not. So, depending on what question we want to answer, we need to look at the particular approach. But I mean, this is not enough, right? As Caroline said, we have very little knowledge about the contribution of the environment and how AMR in human-animal populations and the environment interacts. So we need we need definitely to fill in some knowledge gaps. And of course, surveillance can give us information, can give us scientific evidence and data. But usually for knowledge generation, research is probably better. So, but definitely I think it's a big opportunity now with all of us sitting together. We heard previously about the interagency working group. So it's a great opportunity to see what are the capabilities, what we can do in terms of using data from the environment to inform our work. And we're sitting together and we're learning from each other, I think, a lot. I've been learning a lot recently about what is possible. And so we start crystallizing a bit what real questions we can answer. But then I will move one step further and say that even if we collect the data and we analyze the data, and there are a number of challenges there too, we're not sure yet, what are the targets that we should be looking at, right? What are the methods that we will use to analyze these samples? Then we need to answer the question, what action we can take when we get these results, right? So, and I think this is a very important question. And this is very relevant for wastewater surveillance, because wastewater surveillance is actually a great opportunity, especially now with the new urban wastewater directive. It's a great opportunity to look more in depth into this. And wastewater surveillance has been used, for example, during the COVID pandemic. We all know about that with a lot of success, and giving us additional information on top of what we were getting, especially in cases where there was little testing in the human population, and we could forecast through using wastewater surveillance, and we could also find new variants and monitor the genetic evolution of the virus. And we also have other very strong cases where wastewater surveillance gives us actionable data, like with identifying, for example, in Europe, vaccine-derived poliovirus, where we know that in this case it makes sense to have a campaign. But for AMR, we're not there yet. We need to, of course, we know, what we know is that what are our primary critical priority pathogens in Europe. And these are currently carbapenem-resistant gram-negative bacteria and also ESBL-producing E. coli. And wastewater surveillance can monitor these types of bacteria, and probably they are valid targets. Now, we still need to decide what are we going to be using. Are we going to be culturing for these bacteria, or are we going to be using genomic methodology to monitor? And there are pros and cons for these. So ECDC published in December a framework for wastewater surveillance in public health, where we set out some principles on how to approach wastewater surveillance for public health, looking both at the feasibility and the public health value. And when looking for the public health value, the added value, we need to, on the one hand, I think it's very important to correlate what we find from wastewater surveillance, for example, with, and probably also from surveillance samples in other environmental sources, with what we see in the human and animal populations, to make sure that what we are to understand how to interpret basically the data, because I don't think we're there yet. But we will get there, I suppose, very soon.
No, I'm sure we will. I'm sure we will. No, thank you very much. It was a long intervention, but very. But you gave us a lot of very valuable information. Yeah, I know. No, we were talking on the phone, and he could carry on for hours. Yeah. Trudy, I haven't forgotten about you, and I would like to hear your views on that. Which, in your view, should or could, or which would be the pros and cons of those different two approaches for environmental surveillance?
Yes, I hope you can hear me loud and clear. And
yep, perfect. Yep,
just to say thanks for the invitation. Very happy to participate in this important work, and just to let people know that I work on the policy area of the Urban Wastewater Treatment Directive, and now we're currently work past the.
Give us a second, the sound is gone. I don't know if it's from Trudy's side. I can hear myself, so I guess it is from Trudy's side. From her side, okay. I don't know if up there somebody can handle this while we keep on with the other panelists. Sorry, Trudy. Maybe somebody can give you some help. Okay, not to stop this. Maybe Caroline, if you can give us your view on this.
Yeah, well, it's which is your favourite child? So very fortunately, Diamandis has given us a great sort of side from the public health, the public health interest. For me, I'm very interested in wastewater treatment. Trudy leads the policy area, but for AMR and the wastewater, that's where I'm very interested in my role. Anyway, actually not just in my role. And I think there's an opportunity. So right now, because of the revised Urban Wastewater Treatment Directive, there's beginning to be a rollout of upgrade in Europe's infrastructure in wastewater treatment. So the last directive was 1991, and that led to a major upgrade of Europe's treatment for wastewater. 2024, and now we've got a new directive, and that runs to 2045 for countries to upgrade their wastewater treatment plants. So that's, at the moment, it's 25,000 plants that are in scope of the directive. It's going to go up to 50,000. We're going to learn lots about AMR and things. So are wastewater treatment plants important in discharging AMR-resistant genes? We know they are, but they're very good at treating it, so we need that wastewater treatment. But then, is there a transmission risk back to humans? Because if there is, through the environment, through the discharges, if there is, then that changes the game about what needs to happen in the wastewater treatment plants. But we don't have that evidence yet. We don't know. Okay, there's no requirement at European level to have this, because we don't know. We don't have any evidence to say it's needed, that different sort of treatment's needed or anything. We don't know. So I was talking to Heike in the break, and this is something that JAMRAI can help with. Maybe have a look at just see what's coming out of the plants, and is there something, what could be the risk? So this is about understanding better the risk presented. It's quite timely, I would say urgent in my book, because if there's only when you've got investment cycles, there's an opportunity, and we've got an opportunity now.
Okay. No, thank you very much. And the last, I'd like to hear Pablo's view. Yeah.
Okay. Yeah. Okay, it's working. Going a little bit further back to the question between what type of surveillance we should be doing. I mean, mentioned, and in the conversations these days, there's a lot about, do we have to look at hotspots or do we have to go a bit broader in terms of surveillance? I think doing surveillance at hotspots is going to be very, very important, obviously, because we have that concentrated antimicrobials and resistant organisms. You know, these seems to be very practical entry points for surveillance and intervention. From the global perspective, what we're seeing though is that that's not going to capture the full picture of environmental AMR. And it's not going to have us understand risk, exposure, and long-term dynamics, right? So surveillance has to go maybe a bit broader, or maybe we need a tiered approach to surveillance as well. Maybe we can look into hotspots for efficiency or actionability, right, to start to move forward. But potentially embed this in wider monitoring and in a wider framework, right, to ensure that environmental relevance and policy usefulness in the end. From UNEP's perspective and maybe from the quadripartite perspective as well, we recently got the mandate to contribute to science and risk-based environmental surveillance, feeding relevant data, and I'm reading literally, into the quadripartite global integrated system for surveillance on AMR, and use that my colleague Dora mentioned, this KISA platform. What we're going to do and where we're going to start, and again, this is very preliminary work, is that we're starting with consultations of experts globally around this. So again, this is still work to be developed, and tying it a little bit in what JAMRAI could help on this. I think, as we've been saying before, the EU is always a best practice example for us. So in that sense, providing also that evidence to us that we can later feed into these systems, I think is going to be something that will be key to steer then intervention, of course. But what we want to ensure is that we have something that's realistic, that's sustainable, and that speaks to all of us, that is actually universal. So that's our global perspective as well.
Okay. No, very good to know. We will talk later about that. Later once we have finished, because we only have 7 minutes remaining. And I wanted to go back to Trudy. I don't know if you... Not yet. Oh, that's a pity. Okay. Okay, then we will go to another question. She's okay. She's back. Trudy, can you hear us? Just a second.
I can hear you.
Yeah, we can hear you now. Go ahead.
Great. Fantastic. Sorry about all of this. I don't know. Okay, so just reminding myself of the question, which was, which I think was whether the surveillance or AMR monitoring is for human health or really for environmental purposes, or for both. And as I was saying, I'm working on the implementation of the new recast directive. So going back, this originated back in 2021, 2022, and through negotiations with the member states and others, we realised, as I've heard other fellow panelists say, that there's a lot of knowledge gaps still. There's a lot to be learned, and so the purpose in the Urban Wastewater Treatment Directive is quite clear. We have a recital in the directive that says we want to do the monitoring now to increase the knowledge on the main sources of AMR, and to further develop our scientific knowledge, and then potentially in the future take action. So we're not doing something now. We have other requirements in the directive where we do a lot of other types of monitoring on things like nutrients or BOD, and if we see that the levels are too high, above a certain level, there is an action required. So this type of monitoring is quite different and what's happening now in the directive is there is a requirement at EU level, so that we're putting in place secondary legislation where there will be an implementing act in terms of a harmonised methodology across the EU for monitoring AMR in urban wastewater, and we'll also be looking at, as well as the methodology, at an appropriate frequency based on our drivers. So we've done a lot of work with our colleagues in the Commission in the JRC. We've been doing a lot of work in 2025 through our expert group and with experts on discussing what would a way forward. And that work is ongoing still, but like we do understand that AMR monitoring can contribute to assessing risks in terms of circulation in the human population. what's coming into the wastewater treatment plant can be measured. We can look at trends and early warning, and perhaps even look at emerging forms of resistance. Again, what's coming into the treatment plant. We probably need to understand what different types of wastewater treatment plant can do. They're not all the same thing. It can be a bit of a black box. And also then to understand what happens downstream when we discharge treated wastewater into the environment, both in terms of replication in the environment and even, what might happen in terms of further possible transmission. So it's a good starting point. The directive will have member states reporting on this methodology by 2030, and we'll be working with Caroline and her team in the EEA on that reporting. And I think maybe that's just a place to start to make sure we all have from our point of view at the Commission. Thank you.
No, thank you, Trudy. We were laughing because somebody was sending me messages telling me to sit down properly that you couldn't see. That's why we were smiling. Thank you, Trudy, for giving this very valuable information, knowing that the surveillance of antimicrobial resistance that is foreseen in the directive is more, if I understood you correctly, to gather data and to expand knowledge about what is happening there, rather to take actions. So you basically want to know what is happening there before and understanding it before making anything. Am I right in my understanding?
Just to be clear, this directive is will come into application next year for member states. But what we have in the directive is an evaluation period. So in 2033 and later, we will evaluate, what we've learned from the data collected to date in many areas, including this area. So in time, there could be further developments in terms of AMR monitoring, which is just regarding Article 17. Part 3 of the recast Urban Wastewater Treatment Directive. It's a very specific requirement, and we'll take it from there. Yeah.
Okay, thank you very much. Look up to the camera, Ricardo. Which camera? It's over there. Okay, I'm sorry. I'm so bad with this. Now I'm lost. Very last question, because we have 2 minutes, and I would like to hear the views of all of you. And I will start with Ignacio, because I wanted to know. We always have like that. We don't really know when we have to do something at European level, if we should do it compulsory and in the same way for all the countries at the same time. A regulation or whatever, or be more flexible and try to foster action from the member states, trying to do something in voluntary scale, and maybe with less harmonization at European level, but with less harmonization at European level, but go ahead, Ignacio.
But more flexibility, maybe.
Yeah, go ahead.
Okay, from our experience, we have worked very closely, as I've said, with the Spanish Medicine Agency. So that results into flexibility, simplicity, and for example, we have defined this information to be included in the leaflet in the package leaflet, regarding duly management of waste medicines. We also have the support of the agency regarding those industrial pharmaceutical industry that place medicines in the market, the Spanish market. They have to participate in a collection system like cigarette, for example. But obviously, AMR is a public health risk, and it's important to widen the territorial scope, I guess. The problem here is, as I've said, the challenge. The challenge in this task to meet is to have a unique legislation, a framework legislation regarding all the requirements that this kind of substances has to be applied in order to manage correctly from an environmental point of view. So I think that's if we continue with member state legislation, there will be for sure legislative barriers, and that would be can jeopardize our efforts in that sense.
Okay, as we are running out of time, can you give us an answer in 10 seconds? Can you try? Yeah, go ahead.
What was the second again? Sorry.
If you think it's better, which is the pros and cons of harmonization via...
So for of course, if you impose, we got both really, because we got the EU legislation on water that's coming through. So Trudy mentioned the information that's coming through under an implementing act in the summer for wastewater treatment. That will guide and that will drive innovation and capability building in the EU. But in Europe, at our European Environment Agency, we have our network of countries. It's called the IONET, and we're able to do things voluntarily and build capability as well as use the experts in the country and it's a voluntary activity. So you can have push and pull, and those are both valuable, especially in such a emerging and rapidly developing area.
Okay, thank you.
Well, in human health, we are used to more voluntary at the EU level, more voluntary and consensus approaches because of there is the principle of subsidiarity. So I think, and I cannot say much more about that. What I want to say is that for EU-JAMRAI, it's great that there is a planned pilot for surveillance, and that will hopefully help us fill in some of the gaps that are there. So we're looking forward and we're really grateful for this work and also grateful for bringing us all together here because this is very important. Thank you.
Okay, Pablo.
Yeah, not much more to add from UNEP's perspective. More than I mean, it's always going to be up to the EU and to the member states. But maybe just to pinpoint that there is an urgency, so that has to be taken into account.
Yeah, you're also right. And although we are out of time, Commission is paying us, JAMRAI, I mean, so Trudy, go ahead and take as much time as you'd like to. No, I'm kidding. Only 10 seconds, Trudy, thank you.
Won't waste, I won't destroy your lunch hour. So in terms of a harmonised approach or national surveillance, like from the EU's point of view, the harmonisation provides the ability to compare data. AMR knows no borders, so we can, it facilitates better approaches in different regions or localities. And also by providing this harmonised implementation, depending on member states' current capabilities, it can help reduce the burden on them, on individual authorities. But obviously there are always national or local pressures that need to be understood. So, from my point of view, both are probably needed and both can be effective together. Yeah. Thank you.
No, thank you. And with that, we are already out of time, so thank you very much. It's been a pleasure having you there. We already have our contacts. We will keep in touch for our work, and you just call us if you need us, anything from us. Thank you very much. Thank you.
Thank you very much. Thank you for this very excellent stakeholder forum. You reminded us how pragmatic we have to be within EU-JAMRAI 2, pragmatic to make Europe the best practice region, and also to remind us that at the end, the final end user is citizens and animals who can be one day a patient with an AMR issue. So you see behind me the QR code for the evaluation of the 3 days. So please scan it and answer to the question. And while you are answering the question, I would like to give a special thanks. The first one for the Austria team. The Austrian team for organizing these 3 days. I know how this work is huge, so thank you very much for hosting us and for the organization. Thank you. We can applaud you. Also, a big applause for the technical team, Chris and his team, for the huge work. You cannot imagine the hundreds of textos we exchanging from here to here with all the team for different technical issues, and it went well, very well. So thank you. Thank you to you. Thank you to the people online, because I know it's not so easy to follow online 3 full days. So thank you very much, and thank you for the people in the room. And now I will press the black button. So, to finish, can you say the countdown with me? Okay? 3, 2, 1. Thank you. Have a safe trip back.